Waalaikumsalam warahmatullahi wabarakatuh.
Good morning, ladies and gentlemen. Welcome to Semarang. We proudly present the second International Conference on Legal and Ethical Aspects of Health Services during Pandemic, hosted by Postgraduate Program Poltekkes Kemenkes Semarang, Indonesia, on 2020. It is a great honor for us to be here and have you to join us. Ladies and gentlemen, for the next 2 days, this meeting will provide you plenty of opportunities to discuss, to share knowledge and insights. Before we proceed the program today, we would like to express our sincere gratitude to the Excellency, Director of Poltekkes Kemenkes Semarang, Dr. Marsum BE, SPD MHP. Excellency, Head of Postgraduate Program of Poltekkes Kemenkes Semarang, Professor Dr. Suharyo Hadisaputro, SPBD KPTI. The Honorable, our conference speaker, Professor Dr. Wilmorat Uwaratupipanit, RN PhD, Professor Kasara Sipriya Jakan, PhD RN, Dr. Emi Nur Jasmi, Master of Health, Professor Nawi NG, MD, MPH, PhD,
mati dulu. Sosok hilang. Hilang.
Audience tidak. Before we begin our main agenda, let us praise to Almighty Allah Subhanahu wa Ta'ala. Hopefully we can finish our task for the next 2 days well. For pray, Mr. Ishaq Ibrahim, please kindly lead us. For you, time is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Ladies and gentlemen, let us bow our heart for a moment, pray to God so that our international conference can be precious to all of us. I will lead this prayer based on the teaching of Islam, and those who are non-Muslim, you are pleased to pray according to each of your beliefs. Alhamdulillahi Rabbil Alamin, hamdan yuafi ni'mahu wa yukafi mazida. Ya Rabbana lakal hamdu kama yanbaghi li jalali wajhikal karim asim bisultani. Allahumma inna nas'aluka salamatan bidin wa afiatan fil jasad wa siyadatan fil ilmi wa barakatan fil rizq wa taubatan qablal maut wa rahmatan indal maut wa maghfiratan ba'dal maut. Allahumma ghfir lana wa liwalidayna walil muslimina wal muslimat wal mu'minina wal mu'minat al-ahya'i minhum al-amwat. Innaka sami'un qaribun mujibud da'wat ya qadiyal hajat. Ya Allah, today, November 16, 2021, in this beautiful place, we gather here to bring about an international health conference. The theme is legal and ethical aspect of health services during pandemic. Ya Allah, guide and bless our heart and our minds with the light of your guidance. Help, help us to speak on your mind clearly. Help us to listen to each other, respect each other, love each other, so that we are included to the blessed person. Ya Allah, you are the one who can fulfill our doa. Rabbana atina fid dunya wa fil akhirati hasanah wa qina adzabannar. Subhana rabbika rabbil izzati amma yasifun wa salamun alal mursalin walhamdulillahi rabbil alamin. Amin amin ya rabbal alamin. Assalamualaikum warahmatullahi wabarakatuh.
Ladies and gentlemen, to start our agenda today, we are going to listen to the committee report from the chief. For Dr. Sri Sumarni, Master of Midwifery, the time is yours.
I'm so sorry to put off my mask. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everybody. With all of my respect to Mr. Director of Poltekkes Kemenkes Semarang, thank you for joining us. Bapak Dr. Marsum, PhD, MPH, Profesor Dr. Haryo Hadi Suprat, Profesor Dr. Haryo Hadi Saputro, thank you. The head of department, all of keynote speakers, all invited guests, moderator, and all oral presenters participants of the second International Health Conference activities. First of all, let us offer attitude to Allah Subhanahu wa Ta'ala, the most merciful God. Because of Him, on this beautiful day, we can gather here to jointly participate in the second International Health Conference. Ladies and gentlemen, this event is the second International Health Conference, which is held for 2 days. This is 16 and 17 November 2021. The theme here is the legal and ethical aspect of health services during pandemic era. The purpose of this activity is to provide information and understanding about the legal aspect of various countries. And this event was held in the framework of the peak of National Health Day celebration atau Hari Kesehatan Nasional tahun 2021. This activity become an event where practitioners, academics, researchers, and various health fields can gather to conduct discussion, share experience, and oral presentation in accordance with their expertise. Ladies and gentlemen, this lovely event involves lectures, students, civitas academia, expertise from Poltekkes Kemenkes Semarang, Poltekkes Tasikmalaya, Poltekkes Makassar, Poltekkes Sorong, Papua, Poltekkes, Surabaya, Erlangga University, Sultan Agung University, Indonesia Nursing Training, Puskesmas Rakit, Omni Hospital Pekayon, and all other participants. Total number of these participants involving of this great event is 333 people, consisting of 176 attendants, 93 oral presenters, and 64 invited guests. Ladies and gentlemen, related of this theme, we presented 5 keynote speakers and 4 invited speakers from Thailand, Indonesia, and Sweden. Ladies and gentlemen, this international health conference can be held thanks to the helpful of various parties. Therefore, on this occasion, let us thanks to Director, the Chairman of the Graduate Program, all committees, moderators, reviewers, all parties, as well as sponsors and other parties that we cannot mention one by one. Ladies and gentlemen, and all other happy participants. The highest award we also convey to all the committees who have worked hard to succeed of this activity. We realize that the implementation of this conference still has many shortcomings in this presentation of events, administrative services, and limited facilities. For that, we apologize profusely. Finally, I hope all participants of this attendance who are attend by online and offline get great benefits from this activity. Thank you so much for your attention, and wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Dr. Sri Sumarni. For the next one, let us invite the head of Postgraduate Program of Poltekkes Kemenkes Semarang to give welcoming speech. To Professor Dr. Suharyo Hadi Saputra, SPBD, KPTI, the time is yours. Pardon, Prof. Could you please unmute your device first?
Yeah.
Thank you.
Yeah. His Extraordinary or Resource Person, the first Associated Professor Dr. Will Morad, Associated Prof. Kasara, Dr. Amy Nursatmi, the fourth Professor Navi from Sweden, and Associated Professor Dr. Yudapong from Faculty of Medical Technology, Mahidol University. And then Dr. Masum, Director of Health Polytechnic of Ministry of Health, Dr. Ariswondo, Dr. Meli, the Academic and Administrative Affairs Assistant of the Postgraduate Program, Head of the Study Program in Applied Health Master, Midfere, Dr. Sumarni, Dr. Martiono, Dr. Gatot, Imaging Diagnostic, and Dr. Bejo. All participants in second International Health Conference, legal and ethic aspect of health services during pandemic, and our college lecturer and our student in postgraduate program, Master of Applied Health Science at Poltekkes in Semarang. Welcome all of you at postgraduate program Poltekkes Semarang to join of second international health conference. The topic is legal and ethical aspect of health service during a pandemic. And thank you very much for your coming virtually. Firstly of all, let us praise and thank to Almighty Allah Subhanahu wa Ta'ala for the abundance of grace and the joy of all of us can still gather in this place without any barrier at all and in good health. We also thanks for resource person, Associated Professor Dr. Will Morat, PhD, Associated Professor Kasara, PhD, Associated Prof. Dr. Yuda Pong, and Prof. Navi, and Dr. Emi. On the occasion, we would like to congratulate the postgraduate program Poltekkes Kemenkes Semarang for organizing activity implementation of conference international health, legal and ethical aspect of health services during the pandemic. The novel severe acute respiratory syndrome, coronavirus 2 or COVID-19, has spread on many countries in the world. According to the world data, COVID-19 in now cumulative morbidity is 253 million cases and mortality more than 5 million. In Indonesia, until now, cumulative morbidity is more than 4 million and cumulative mortality 103,000. The impact of the pandemic COVID-19 are many influence aspects, including of ethic. We know that all health workers, including doctor, nurses, midwife, dental, hygiene, radiographer, nutritional laboratory analysis, environment health worker, and other health worker are required to provide services by prioritizing quality, effectiveness, and most effectiveness. Healthcare provider must have a good understanding and competence and theory or science and implementation of legal and professional ethics. This is the need for combine on both ethical ethic and health law piece become the event where practitioner, academic, and observer in various health will be supported in developing sophisticated international perspective on ethical issue, ethical dilemma, and or code of ethics. The purpose of implementation this activity are providing information and understanding about legal ethics of various countries during COVID-19 pandemic, and providing information and understanding about professional ethics of health worker, and providing information, understanding legal conduct to avoid violation and providing health employment practice. The participants of this international and the second international health conference are health worker, practitioners, academic staff, and health students. So I hope the activities will give all participants, student, lecturer, practitioner, a better knowledge, mainly of ethical health aspect. Thank you for attention. Wassalamualaikum warahmatullahi wabarakatuh. Enggak.
Could you please turn on your mic, sir? Okay, we can see you now.
Okay, thank you. Is here? Hello?
Hello. Yes.
Is okay? Okay. Thank you very much. From MC. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi dan salam sejahtera untuk kita semuanya. Salam sehat. Sehat Indonesia bersyukur. Good morning everybody. Best regard, best wishes for all of you. The honorable all speaker, both from overseas and from Indonesia, distinguished guests, especially Professor Dr. Particularly Professor Dr. Suharyo Hadisaputro, SPD, PD KPTI, and Miss Dr. Sri Sumarni Emit as Chief of Committee, and wonderful participant. So, ladies and gentlemen, allow me in this opportunity to welcome all of these conference participants by first praying our gratitude and praise to the Almighty God for all His blessing, grace, and mercies that have made us possible to get here in this room in excellent condition and health. Dear keynote speaker, distinguished guests, and participants of the second international conference with the topic legal and ethical aspect of health services during pandemic. Postgraduate program Poltekkes Kemenkes Semarang is very pleased to host this conference virtually using live video conference. One of the vision of Poltekkes Kemenkes Semarang is to be recognized internationally. And one of the efforts to achieve this vision is by establishing cooperation with foreign institutes by holding this online international health conference. Nowadays, the world is facing many challenges. Mostly in this pandemic, the coronavirus spreads around the world and pushes us to be more innovative, especially in the health sector. We must address the sustainability agenda to deliver improvement in efficiency and resources productivity. Legal and ethical aspect of health services during pandemics become an important problem for all health providers because we can use our common procedure in the healthcare center. some protocol should be followed by all care providers to stop the transmission of coronavirus. The government, with all healthcare professional, is very country has made regulation depending on their country's condition. We should be clearly aware of the importance of interdisciplinary cooperation. We need to promote cooperation within the profession and also with natural and social scientists and the public in the creation and application of knowledge for enhancing nation productivity and competitiveness in this pandemic. By holding this kind of international conference, I hope that all participants could share information interdisciplinary across the country so we can learn together and be stronger to fight this pandemic condition by increasing our knowledge. Once again, thank you to the excellent speakers who have been willing to share their knowledge with us. Thank you too to the Committee for Postgraduate Program for holding this online international health conference. And the last but not least, thank you very much to all the participants for joining our online health conference. Before I end up my speech, let's open the second international health conference event by saying Basmalah together. Bismillahirrahmanirrahim. Hopefully, this event can run smoothly and bring great benefit to all of us. I apologize for all my words and behavior that unpleasing to you. And thank you very much for your attention. Before I close my speech, let's read the little pantun. I cook rice. Rice grows in the middle of rice field. We open this event nice. We would like to express our glad feel. Go to the market to buy fish. There are only 2 fish in the location. Thank you very much. I really wish we will see in another good occasion. Thank you. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Our NCSC and our NCSC.
For this first session, will be led by our moderator, Mr. Mariono, MNS, PhD. First, please kindly allow me to introduce him. Mr. Mardiono, MNS, PhD. He was born in Sukoharjo, 12 June at 1970 and finished his study in Thailand. And without further ado, to Mr. Madiono, MNS PhD, the time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Ladies and gentlemen, we have a good time to have attend the International Health Conference. We will have two speakers. First speakers, Dr. Wimon, and the second speaker is Dr. Kasara Sri Pacakan from Faculty of Nursing, Chiang Mai University. I'd like to hear to, Dr. Wimon. Before okay, I'd like to read the curriculum vitae Dr. Bimonrat Pawara Wutipat. She is Associate Professor, Head of Medical Nursing Department. She graduated from Middle University in 2004. And her expertise in chronic illness, especially neuroscience nursing and nephrological nursing. She also have several publications and internationals, mainly regarding the hypertension and the neuroscience. So we can have opportunity to have knowledge from Dr. Wimonrat. She will present care of the hypertension crisis in Thailand. Sawadikap, Achan Wimonrat. Before Dr. Wimonrat started the presentation, I'd like to have opportunity to participants. You can raise your question directly, or you send a message from to the WhatsApp. I would like to give some questions to Dr. Wimonrat to elaborate further. And especially to Dr. Wimonrat, we allocated time for presentations, approximately 30 minutes. Certificate, Achan Wimonrat, can you respond?
Okay. Did you hear my voice? Did you hear my voice clearly?
Yes, Ajahn.
Sorry, because the first that I cannot speak and respond you because microphone is not allowed for me. But now it's my turn, right? It's my turn, right?
And
So I need to share slide by myself. Can I?
yeah.
Okay.
We can have to operate your slide, Ajahn.
You operated my slide because I would
Yes.
like to share my slide by myself. It good. Okay. So the first slide that I told you that Madi, would like my to specialize in care of hypertension crisis in Thailand. However, the theme of international conference is legal and ethic aspect of international professional collaboration in caring of non-communicable disease. However, before I start in detail, I can say that interprofessional is like it's a model aspect, but it is very important aspect in the 21st century because it will be like a patient-centered caring for non-communicable disease. Not only non-communicable disease, is also play important role in the COVID-19 crisis in Thailand also. I can say that legal aspect in Thailand now about the care of non-communicable disease. I think that they still have it a few, but it a few because in Thailand we have like a council in nearly every professional. So the professional have like a society for themselves and clarify the law. However, the ethic aspect, I think that it still have in every country in the world. So that's why when I would like to share the care of hypertension crisis in Thailand, I would like to say to focus on how to running the process of interprofessional. So the first slide show the campus of our faculty of nursing in Bangkok Noi at Sirirat Hospital and also in Salaya. In the light side of presentation is Salaya campus. The outline of my presentation is interprofessional education. I will speak a little bit for understanding about interprofessional education in Thailand. And also, I would like to show how to running the process of interprofessional. And you can see that if you run on this process, the legal and ethic aspect between interprofessional will be like a maybe reduced by the process. And because we have like a meeting, so the conflict between the professional will be reduced by the process. And I will show some hypertension care in Thailand is the best practice that WHO that mentioned for our country for our campaign, and we can say that hypertension care in Thailand is the best practice for us in non-communicable disease, and it is like a good model for Thailand. Even though we talk about the best practice, but we still have another problem. So I would like to say to you that how to conduct or continuing challenges in hypertension control and interprofessional education will go further for 21st century. About the interprofessional education is a policy of Mahidol University. And also, I think that it the education policy in Thailand also, because it is it is a vital and it is a necessary skill for our graduate and undergrad student. And even though after they graduate from our faculty of nursing, it still have the law in the interprofessional practice. This is our paper in our department that we try to running the process in the in the curriculum of bachelor degree of nursing to start with preparation of interprofessional practice that we move from the theory to practice for nursing student in Mahidol University. And I think that last year we have the publication in Silat Medical Journal. You can find from the Google, you just key and typing for the title and you find the whole paper for international. That I mentioned earlier, the ethic of interprofessional collaboration is like widely mentioned that they still have, and interprofessional collaborations have become accepted, important, competent in total healthcare. After graduate or after you work, you choose concern about patient safety care, patient-centered care, holistic care, and the quality of healthcare that conduct by interprofessional collaboration, and still like the ethic play important role like a key message between the professional. So the communication is a key message that we find in interprofessional that should work together. From the paper of Lancet, Lin Chong, Chen, like a chair of China Board of Medical Funds, say that health professional for a new century, it is like a key role for transforming education to strengthening health system in the dependent world. Why they say that? Because you know that health system is quite complex in the future. You just have, and I think that the population of our just faced with the COVID-19 and still faced with this problem in the world. So you see that the complex health system that conform epidemiological and demographic transition in our world in the healthcare system. And the professional is differentiation, and they have variety of professionals that work together, and they still have population demand from the health system. And you say that in this era, the technological innovation is very important role for outbreak. You can face with the 5G or the digital era in the world. So it is emerging challenge to our health system. That this paper just a little bit say that when we work in healthcare system, the professionals should go back and study and work together with education system. It is an education system, it is a subtype of health workforce in the future. So it would interchange together in the future, even though we like have the different role. So you can say that what are the difference? You say that the dominant is we say that the common that we work together in doctor, nursing, public health, we work like a teamwork. So we can say that we work like a teamwork. If we is it common, right? Is it we have interprofessional? It's common also. We also call and specific competency together, and we have much more systematic teamwork. So we call say that teamwork and trans professional. We say that is common that we see in our world. We have like a core and specific competency also in each professional, and we also work like a system. We consult teamwork in the practice also. However, this is we call that is community of health workforce. So they have several models for interprofessional and trans-professional education. So that's why in this era, the transdisciplinary teamwork is quite important in the nowadays at the present of our world. So why we can work for interprofessional? It is a vision for new era for professional education, because we would like to build the gap to cross the equity in the healthcare system. So that's why we can say that the population base and patient care center is really important. So like policy care is important. So WHO also focus on international framework and education also in this era. And this is the framework of WHO for action on interprofessional education. So if we would like to outcome to improve health outcome, you see that interprofessional teamwork should see the goal together, right? If can if we cannot see the goal, the same goal together, the collaboration is difficult and it is impossible. So healthcare system and healthcare education should work together. This is the basic how we work to reduce legal conflict and to reduce ethic issue. So we can design IPE model. You can see the word IPE is come from interprofessional education, and also IPP is interprofessional practice. It means that we apply some education to practice. So that's why the teamwork in the healthcare system should come back to work and to learn together in the education system. We can design intercurricular activity in your subject, in your nursing college, in your nursing school. We can work and campaign in healthcare team. It is some word it's in Thai because I present in nursing council recently allowed 2 months ago. And we can design extracurricular for activity also because so I think that I share experience that in our department we kick off the project of international education come to and move to interprofessional practice with faculty of medicine. You see the life side is the medical doctor and also like a pharmacist. We work together to kick off some curricular and education in the medical unit. The first day that we kick off, we work in every unit and share some idea how we work together, so we can reduce some conflict. So that's why I told you that I can say to you how to reduce conflict, a legal aspect, a legal conflict in interprofessional education. In Thailand, we like have a good luck because we have like a association for professional already. So we like have legal framework and ethic framework for each professional. However, we still have the gray zone. So we together we talk and discuss when we met at the first day for kick off the project. This is the associate dean of the undergrad program in the faculty of medicine Sri Lanka. We pray together and we like show together how we conduct with nursing student and also in medicine student. You see that he is really famous in the heart disease in Sri Lanka hospital. See, we work or you see that in table we have the doctor, we have a nurse. Some table it like some staff is very busy so they cannot come, but the leadership are in the unit like a head nurse and the doctor and the chief doctor in the unit come to receive policy from the meeting, and they come to the joy and to join the meeting in the unit. So it means that we learn from policy to bottom. We don't use the common practice that we know together like a common team, but we work at the policy. Like I told you that Mahidol University, we learn from policy to practice. So this is the outcome that we discuss together. We start with the common practice together and merge with policy. So we say that in our medical unit, we have like some activity together already. So we start to that point first. And finally, we summarize when we met in the first day, how we work. So you see, is it the goal? I told you that if we cannot see the goal together, we cannot achieve the conflict or reduce the conflict, illegal conflict, and to like an ethic conflict. Why interprofessional competency is important? You see, at the first goal of interprofessional, we can share ethics, we can share the legal, we can share the rule together in each professional. We share the value. So it means that in each professional, we have their own value. We share the role. We share responsibility together already. We share the teamwork and leadership in each role. So it means that if we work together, we meeting, we conduct the process together in each project. You can see that in each professional, they still have the leadership by their own in their practice area. We learn and reflection together to have a critical thinking. We have communication between interprofessionals. So that's why I told that ethic issue that I told you in the first slide, in the previous first slide, can show that interprofessional and communication can reduce the ethic conflict and legal conflict in between interprofessional. So I think that in the area that just things start, so the process of interprofessional education is quite important. So if we learning together, we have learning process together and ascent process together, we will know in each other. So the technique that we work together, we use brainstorming in the care team. Okay. So this is the goal of interprofessional in the patient outcome because we need to improve. You see, in each professional, in interprofessional practice should know their responsibility, should know their accountability, should know the gap of interprofessional practice, should know how to coordination, should know how to communication and respect together, should know cooperation and assertive, you can say autonomy by their own professionals. So the legal and the ethic issue will be reduced by the process of interprofessional practice or education. So in the medical unit, we work firstly, we work in 3 professional: medical doctor, pharmacist, because in the working area or in the touch point, it means that bedside nursing, we have like mostly of 3 professional. The meaning of interprofessional education that we work 2 professional or more. That is the role. If you have 2 professional like dentists and nursing, you can work together to interprofessional, and we learn and reflect together, and we communicate together to leading and move the unit. How we give the skill to the student, we give the soft skill and hard skill. Hard skill is practice. Soft skill is the idea. So we manage and we like put some soft skill, time management, creative, persuasion, collaboration to our student to make in each professional in each student will know how, what are their role. Okay, so this is the climate in medical unit that we work together in. This is the ID doctor. He is very famous in COVID-19 because in our department, especially me also, we work in the COVID. And we have like a specialized program infection control for 4 months. And nowadays we like a 2 years ago, we focus on how to manage men of COVID-19 in our country. So in each unit, we work together in medical student and also in nursing student. We work like okay, you can see that she is really famous in diabetics. So it means that we work together in medical unit, not only in non-communicable disease. We have like chief doctor, we have the variety of expert in our unit already. So we can do in this point. I think that I nearly have a few times, right, Madiono? So I think that when you would like to give some situation, like you would like to care in specialty in some disease like COVID or hypertension, you should start to with the situation analysis. You see, we review. You should review. So I gave some slide to you already. You can go and review. how the trend of worldwide, how the gap of the problem that interprofessional should work together. About hypertension, we know that hypertension care, the detection, treatment, and control is like we have a gap in valley area in our the world. Still have the gap in Thailand also. So we review from the review or systematic, and we know the problem in a substantial in the worldwide, and even though the same region they have the same problem, even though in Thailand, even though they have a large improvement in the middle income country, it still have some strategy. Like in Thailand, we have universal health coverage and primary care that we like to use like a strategy to control hypertension. And hypertension care in Thailand, we can say that it's like a best practice in our country. We give like a model, and WHO is can say that hypertension care is a best practice in Thailand. So we start a situation analysis with the burden, right? And we go with the situation analysis, and we focus on what can we go further. And we have like collaboration in healthcare system, in interprofessional education. See, okay. So, and I think that another strategy is the facility care in Thailand. We should analyze it also, like the hospital of province, the district, and the university hospital. What are the difference between the healthcare system? And we fill the gap with interprofessional education. See, this is the loan of the healthcare center or healthcare district in Thailand. So this is the work at the primary care that the nurse loan work together. Okay, we like a conduct and support facility for treatment for hypertension. We have a guideline. See, and I told you further, we will also focus on interprofessional. Why? The human resource for hypertension and other NCD service is quite important. So we like have the short course training for physicians, nurses, and pharmacists, and also data recorder like IT man, and also physical therapists, to much more understand the way that we would like to go together and the goal that we would like to achieve in hypertension care. And we also like have the short course training for volunteer. We call also more in that they work in the healthcare system. And we know that the problem is screening, detection is still have problem. So we launched the program of screening in all over the hospital and community care, you see, and we have also the guideline, and we have the guideline for treatment, and we have the system for monitoring. So we can say that we have also data center for monitoring and indicator for target also. So even though we can say that hypertension is the best practice and success factor for our country, we still go further, because we can say that evidence-based program is still have for us, because if we would like to do better, to do the best, we still have like a program for evidence-based practice for our nursing and also our healthcare provider. I can say that challenging in hypertension control is still going on in Thailand. So challenge should go further, and we also focus on like a control of hypertension is underestimated in all over the world also. So this year, the World Health Organization campaign about hypertension in Hypertension Day is measure your blood pressure control is live longer. So it means that control of measurement still have the problem in Thailand. So in my experience, I would like to show a few about our experience in metabolic syndrome that I and our team work at district health system. I and me and our team go to the district health system. Is it our student to have situation analysis, and we work with interprofessional like a doctor and like a physiotherapist also. And we also apply chronic care model to our research also. This is our work. So you can look and see our slide for my presentation. So I like to give you a message that the legal issue and ethic issue for non-communicable disease can reduce by you make the true process for interprofessional framework. Thank you.
Thank you very much, Dr. Wimon, delivering the speech explanation about best practice in Thailand. We can discuss further after Dr. Sarah Kasara speech. I hope Dr. Wimon is still in the Zoom and be waiting for Achan Kasara to deliver the presentation. After all, we can discuss together. I'd like to invite Dr. Kasara. Sawadee krap, Achan. Waiting for Dr. Kasara response. I'd like to present her CV. Dr. Kasara Sri Pancakan, Associate Professor and Chairperson of Midwifery Research Center, Faculty of Nursing, Chiang Mai University. Her expertise related to violence against children and women, brief defect and fetal newborn development, and we know the strength of Chiang Mai is qualitative research, particularly in participatory action research. Her publication related to maternal newborn nursing midwifery and others related to maternal and effectiveness children providing health education during pregnancy. She also author of many books such as Euthanasia and Nurses Rule, Nursing Care of Women Inflicted with Family Violence, Nursing Care of Women with Premature Labor, Nursing Care of Women with Dystocia, and Preconception Care. And the last one, Food and Pregnant Women. Sawadee krap, Achan Kasara. Can you hear from the Sawadee krap, Achan Kasara?
Okay, good morning.
Good morning, Achan.
Yeah.
I already summarized some your CV, and now I'd like to invite you to deliver your material, approximately 30 minutes. After all, we have discussion together with Dr. Wimon from my university.
Yeah.
Now, time for yours, Achan.
Yeah, okay. Salamut pagi. Good morning, everyone. The organizer, may I share my screen by myself? It would be better. Can you hear me? May I share my screen by myself?
Yes, we already.
Okay, this one.
Okay, ready, Achan.
Can you see my slide?
Yes.
Anyone? Okay. So it's honored to be a speaker in this interesting international program. So I am assigned to present about legal, ethical aspect, especially for mom and kids during the pandemic. So the main point will be bioethic. Okay. And so when we talk about law and ethics, we need to talk together like a jigsaw. And another one is morality, because for law enforcement, we cannot ignore about ethics and moral. We need to consider simultaneously or at the same time. So I call ethics, morality, and law jigsaw. And let's start with law in Thailand. There are three laws. The first one, emergency declared on public administration in year 2005. The second one is communicable disease act, the year 2013. And the last one, Child Protection Act, 2003. So let's start with this one is unofficial data from this website. Is a compare between Thailand and Europe, but I have no idea in Indonesia, so you may discuss or participate. For emergency situation in Thailand, we use this one during the COVID, and many things. We have curfew and no alcohol selling, close the school, close public park, and close department store at the beginning. But now we change because curfew at the beginning we have curfew, but now only in some province. But in Europe, in Sweden, there are quite no curfew, they don't use much law about emergency law for this one, but in Germany, France also use it. Okay, talk a little bit about the emergency situation in Thailand. This law normally we use when we have political conflict, but during the COVID, we also use this one. And the other committee, the Center for COVID is established. And the committee composed at the national level, Prime Minister and the chairperson, and all ministry to be the committee. And at this team make sure the first one is about public health. The second one, disease prevention and control. The third one, information and public relations. The fourth one about foreign affairs. The fifth one, security. And the last one about supplementary is announced in the government guests. And many guests were announced at the beginning.
Hello, Ajahn. Hello, Ajahn. Hello, Ajahn. Hello, Ajahn. Hello. Okay, please continue, Ajahn Kasara.
Can you hear me?
Yes, Ajahn.
Okay, can I continue?
Yes, sure.
Okay, thank you. Sorry. This is the example that we use under this kind of law. And move to this one. Thailand still have political protest, but during the COVID, you see, we not allowed to gather more than 5, but now there are more than. But sometimes we cannot prohibit. So you see some put on mask, but some did not. Okay. So move on to the second law, Communicable Disease Act. The first one, healthcare provider is legally mandated to provide emergency care for the COVID case. So we cannot refuse emergency care to everyone, including pregnant women. But in private hospital, they tend to not provide emergency care for pregnant women because it's more complicated. But it is announced that you cannot do that. It's legally mandated. You need to take care emergency case. But here comes the ethical problem. Yeah, these parents and their kids got infected, and they said no hospital admit. Actually, they said they had the right to choose hospital, but they choose the private hospital. So every day we face a lot of problems. So next time we solve this kind of problem by and now that the patient that get diagnosis, if you got infection, you need to follow that hospital. That hospital will hospitalize you. You cannot choose to other hospital. If you want to choose, you need to pay. For COVID case, it is free of charge by the government. But if you want to choose to private hospital, you want to choose by yourself, you need to pay your own. Another problem is about resource shortage. So this is crying because there is no, during the crisis, there is no oxygen supply, no bed. Okay. So after each crisis, we have opportunity. So there are a lot of volunteers in health, in hotline, food, prepare food for patient, for doctor, health personnel, donation, and about communication and many things. This is the example of the taxi driver that a volunteer to give transportation for health personnel. The second one under this law is mandate for healthcare provider to notify the case that it is every day we know how many new cases, because every province, every hospital need to notify the case to the center. And the third one is for lay people or for patients to disclose if you are infected. But come the problem to women cross the border without checking the immigration office, so we cannot detect that she got the disease and she spread the disease. So we enforce this law to allow us to go. Another problem is about privacy. When we need to disclose, some people, especially for the movie star, they have their secret, right? At the beginning, many movie stars would like to disclose the timeline if they get infected. But some celebs, they have their secret, right? Secret activity. So they said it violates my privacy. Actually, you don't need to show, you need to tell what that is about you. You just now the hospital or the center keep confidential about the patient, but just tell where if you go to this page, you need to check, you need to get tests. So the first one under this law, Communicable Disease Act, is about get tests. If you get exposure, you need to get tests and get treatment. So come the ethical issue about the right to refuse treatment. Can I refuse treatment? And about the the right to refuse quarantine. Did official governor notify the police for one patient did not want to stay in the hospital? So we enforce the law for this case. Another case, this guy is fined for 20,000 baht because he did not have 14 quarantine after he exposed to the infected case. So we use the law to control the disease. And another law in Thailand is legally mandated to put on mask. Yeah. And the first one who get fined is the Prime Minister. He did not put on mask during the meeting, and he was fined 6,000 baht. This one is the punish someone as the example for others. Don't do this. You need to put on mask. For these two kids, they try to put on mask because teacher told him you need to put on mask all the time, and told your parent to put on mask all the time. But he cried a lot. The both cried a lot because he said, "I lost my mask. I did not put on mask. I did something wrong." Actually, the mask is under his chin. You see, so sometimes law enforcement is not used for all people. It's used in some situation. So law is not the final say. Another law is a Child Protection Act. This law is, I think, it's similar to other countries. This law actually is legalized for the problem of family violence or child abuse, but can be applied in the COVID situation as well. And doctor, nurse, security, social worker, and public health officials are mandated to protect a child if guardian or parent cannot protect the child. Okay, so which one important between law and morality? For this one, law is not the final say. This one, nurse or healthcare in one unit are crying because all of them were infected because the patient did not disclose about his exposure, so they cry a lot. That patient, he know the law that he need to disclose that he has some problem. But the way to control not just by law but by morality, moral thought. So when these pictures are distributed, many people have a lot of concern. We should not conceal. We should disclose if we get infected or if we are at risk. But the way to disclose, you can keep some confidential. You don't need to tell your identity. You just tell timeline. Another one is the good example about moral thought. This guy, he refused to do quarantine. He joined with his neighbor and drink alcohol. So under Thai law, not allowed to drink alcohol during the COVID. And he know the law, yeah, he knew the law. But the health volunteer, one health volunteer, come and talk to him. You have to be responsible for society, haven't you? Responsibility, social responsibility sometimes is more effective than law. So come to the topic ethical obligation. According to the WHO, healthcare provider during the pandemic need to work under 3 categories: moral, professional standard, and legal. Not only law, but morality and professional standard. So let's talk about bioethics, morality, and law jigsaw. So they are jigsaw. We finished about law. How about bioethics? Bioethics, the principle, at least 4 principles. The first one is beneficence. The second one, non-maleficent. The third one, autonomy, and the last one, justice. How about morality? Culture is related to culture, religion, Muslim or Buddhism, Christian law. Sometimes law under the moral can be regulation or rules, responsibility, ideal, professional standard, and so on. Under law, bioethics and morality, it comes from the at least two philosophy: milk, utilitarian or consequent. The get good for the get number. This principle, yeah. If we get the more benefit, we choose that one under this principle. Another principle is about Kant, the ontologism. It's about right or wrong. We do the right thing. We don't do the wrong thing. We need to follow the rule. We need to do our duty. We need to follow our obligation. So we need at least both of them to come up the jigsaw of law, bioethics, and morality. So let's talk a little bit about bioethics for principle. And another jigsaw of bioethics is morality. So if there are conflict among each principle, many principles, sometimes they get conflict. So we need to take all the principle into account, consider all principle, not just benefit, not just about autonomy, not just about justice, or for principle, including morality. And for beneficiaries, is the benefit. So the question is the benefit of whom? Mostly by the benefit of patient and larger to their family, to community, to society, and the benefit of the country. And in terms of health maximization, efficacy, high efficacy. The second one, non-malefficiency, do no harm to whom the state and benefit. We can do harm to patient, to their family, to their society, and to the nation. The third one about autonomy of thought, intention, and action. It's about informed consent, truth theory, and confidentiality. The concept under autonomy is that the power to make rational decisions and moral choice. It should be allowed to exercise his or her capacity for self-determination. This one, the one who do self-determination need to have capacity. For children, sometimes they cannot make decisions by themselves, so the guardian, the parent can determine for them. So under autonomy is about the right, the freedom. But another thing we cannot exclude is responsibility. When we have right, we need to have responsibility as well. Justice is the fair to all. About it is also equitable or equal and appropriate of equipment, test, medicine, treatment, equal time, and so on. So this one I think a bit difficult to make judgment for equitable. Equitable means measurement according to need. Who need? If you need, you get that one. It's about effort, contribution, merit, free marketing exchange. So I have the example about this one. Dada Kulang, yeah, is the Indonesian sweet. I never eaten before, but I've been in Indonesia a couple of years ago, before the COVID, and I visited our tourists. I visit Borobudur Buddhist temple. It's really nice. Indonesian people is really kind, and the food really nice. And I ate lots of salad, a fruit, kind of fruit. And this one, it looked really nice to me. I never eaten it before. based on the equality. If there are 7 pieces, this one 7 pieces of pulang. If equality, if there are 7 students, if they don't mind for the top one, doesn't look good, but the amount is okay. So everyone feel okay that we can eat one of them. 7 students will get one of them. We call equality. Yeah. But for equitability is another concept that it seems like one student, oh, I don't like this one. It doesn't look good. I want this one. Or everyone want the nice one, but at least one. But there are one piece doesn't look good. So how we make judgment? Who is highly need? About need, effort, who have high contribution, about merit, free marketing exchange. So if we use this one and explain to students, I use this one to make judgment with. How about this one to go to who we have how to make judgment. So under the justice, there are some topics about distributive justice. It's about the fair, equitable, equal, and appropriate distribution of healthcare resources determined by justified norms that structure the term of social cooperation. Another justice is procedural justice. It means receive the same treatment. Every treatment, everyone need to have the same. Okay, we move on to ethical decision making. It's a process, not linear process. It's the circle process. Start with problem. We need to identify problem and results. Result is about facts. How to get facts when we make ethical decision. We do clinical assessment. We do patient preference, what they prefer, quality of life, which one, what does it mean, quality of life, and the context. And after we decide, we got the fact, we identify the alternative, potential alternative, and then analyze. The analyze step is the most difficult one. We check all results of fact and principle, bioethics, principle and morality into account, and identify the conflict between each principle, any conflict, and weighting, balancing, which conflict is more important, which principle is more important, and we need to turn to ethics literature, consult the literature, and consult expert opinion. After that, we make decision, choose the solution, and implement it. When we implement it, we need to consider about the side effect of that solution. Every solution have its own side effect, so we need to identify the side effect and prevent it. After we implement and prevent side effect, we monitor the outcome. Is it okay or not? If not okay, we come back to the first step and do it like a circle. Let's talk a little bit about expert.
Sarah,
Yes.
could you give a short explanation because we have discussed in advance.
The time up, right?
Yep.
Sorry, I cannot hear. The time up, right?
Yes, you can sum up the last part in brief.
Okay, I have to finish. Okay. So you can study from my PowerPoint. I have no time to sum up. There are a lot of things to present, so I can end my presentation and we can discuss. Okay. So any question or any thing would you like to ask or comment? It's open now, open discussion now. Sorry, I cannot finish my PowerPoint.
Thank you very much. Dr. Kasara Sripicakatiakan. Now we have time for discussion with our speakers. I'd like to have a direct question. If any participant like to ask the question directly. Waiting for the questions. There's question for Dr. Wilmon Rat. Hello, Achan Wilmon Rat.
Yes, I'm here. Yes, you can
Okay.
ask question.
Yes, question for you. How to balance and optimize the soft skill of nurses in the era 4.0, demand for interaction, technological advance. So we should consider the ethical aspect to run the properly. Time for yours.
Yes, I think that first that in your curriculum or in your patient-centered care, you know the outcome already, right? You can say that what are the soft skills that do you will see or in the service care would like nurse or would like to healthcare provider to have the manner. For example, in the service care, they would like the soft skill like the nurse or the healthcare provider to pay attention for caring, to concerning, to have the skill of the decision making for by using the evidence-based practice. You know this, and you waiting and you balance what kind of skill is necessary for our professional, for our interprofessional, and the skill we have to like a hard skill we have to pay attention in the law of interprofessional, like a doctor they like a have prescription, they have skill to like to communication the bad news, something like that. And if they would like nurse to have the soft skill or the hard skill, the committee of the curriculum or the committee of the unit can discuss together, and we like a run PDCA, can do check act, right? Like you like to do routine to research to routine or routine to research. We know the problem, what kind of balance in our center should have. We can say that. So it depends on the situation and the problem that we need to do. And also, I think that the ethic and the legal aspect also. But I think that the aspect of legal in the interprofessional, we have the council. I told you already, we have like the council, we have their own like the act or the law that concern about professional already, right? So if something is not clear, we like a have meeting between professional and clarify together. Yeah. Another question?
They applying the interprofessional educations
Yes,
and
you can, and practice also. Nowadays, in the professional of practice, you should like in service training. So that's why the Lincoln paper in the Lancet say that the healthcare system in complexity. So the healthcare team and healthcare resources, especially in human resource, should have education on time and mix and go and back to study. And then if you have enough knowledge to go to work, both sides should work together in the discipline. So that why in Thai Nursing Council, they try to match between health education staff and match with healthcare practice to running the course of a specialized program should have both sides together between the committee of both sides should have like two or three proportion. Next question. or any
Okay, Ajahn.
discussion to share. You can share in your situation.
One thing, Ajahn, after applying the interprofessional education since 2016, that the outcome, the hypertension remains stable. Could you share what the
I think that it not stable. It depends on the area. So that's why the World Health Organization is better. I mean that it's better. But in Thailand, we still have the problem of the tech. It means that so why the World Health Organization campaign about the blood pressure control should measure the blood pressure by yourself. So in Thailand now we try to campaign every people in Thailand to like have a home blood pressure by themselves and monitoring and send some message to like a healthcare provider in the community or in the hospital. We still have the problem, even though we have like a universal coverage. So we still going on and explore some issue and some the way forward to solve the control of hypertension. We still have the problem, but it's better. It's better. I can say it's better.
Thank you very much, Ajahn Memorat. The next question goes to Ajahn Kasara. To what extent midwifery in Thailand care for pregnant women or postpartum women who got the COVID in Thailand? And one thing, any aspect, religion aspect, I mean Buddhism aspect, involved in the COVID care to pregnant woman or postpartum woman, Ajahn Kasara?
May I share my slide? This one, can you see? Can you see my slide? No, is the
Slideshow,
huh?
Slideshow, Ajahn.
The rate of infection among pregnant women is almost 5,000 cases, and the death rate is around 95 cases. So more severe 2.5 to 3 times of non-pregnant women, and the death rate is around 2%, similar to other countries. And for the baby, infection rate 3 to 5%, and the death case in Thailand, infected case around 200 cases, and death around 40 to 50 cases. So for Buddhism, Muslim, the problem is it's not the issue about abortion, because it is not the indication to do abortion. It might get infection during the first trimester, and it's about the religion is about the vaccination, not related to mom and kids, but there are some fake news that for Muslim is not allowed to get vaccination, and after that the committee has announced that the producing process of vaccine is not related to some animal not allowed in Muslim, so it's okay to get a vaccine. So after this problem, it come up with among pregnant women, the symptoms are similar to non-pregnant women, but the higher rate is controversial, not inconclusive. Get higher risk about vaccine counseling. So after the WHO announced that it's safe to get vaccine, but should be during the second to third trimester. During the second or third trimester. So every kid will get counseling about vaccine. And for the ATK case, is allowed for women to get priority to get the test. And the infection rate is high due to workplace. So it recommends mom to work from home. So that's all about mom and kids. And next slide is about cesarean section rate. Yeah, it's really high. We tend to do cesarean section 55%. Normally it's around 10 to 20%, and preterm birth is more prevalent, 18%. Normally we got around 10%, and low birth weight, low baby, higher, 16%. So when we take care mom, we have, when the patient die, we have dying alone, because the funeral needs to be done within 24 hours to prevent infection, prevent the spread. So this women very far away from the funeral ceremony and alone. And normally we have around 3 to 7 days for the funeral ceremony, but this time, and not a lot of people to go to this funeral. We call dying alone. And for mom, she giving birth alone, because that time we don't have the test kit. So we don't know who get infected. It's not allowed husband or family to attend during in labor or postpartum. But now we have the test available of the test. We get the test. If you are get the test, if negative, you can visit mom. Okay. And breastfeeding is we follow WHO and UNICEF recommendation. If no symptom, if no drug, favipiravir, mom can give breastfeeding. Or if mom already get vaccination, you can get breastfeeding. But sometimes it recommended by VVKIT that individual counseling should be done, because not all case, some case they have more different context. Some case may not fit to get breastfeeding. So don't use only public health recommendation. This is a general recommendation. Midwife need to provide individual counseling and balance between precaution and parental decision making. Okay. I spent too much time. Should I continue?
Very much for your explanation and sharing the caring for maternal patients in Thailand. And I'm sorry we don't have enough time. Maybe we can discuss in advance in another patient or in the study visit. Before end the discussion and the session, I'd like to present the certificate to Associate Professor Dr. Wimonrat Pawara Wucita Panit. Give applause to our speaker.
Thank you very much. And I have the honor from Semarang University, and hopefully that we will join together in academic, in every aspect of academic, in our Faculty of Nursing. And thank you on alumni that visit our faculty. Thank you so much.
Thank you, Achan Wimonrat. We can see next year, I think, in your conference. Yeah. And honor to Achan Kasara, Sripi Yakant. Give applause to her valuable speech and explanation today.
Yes. Thank you very much.
Azan Kansara, maybe Azan Rujati will continue discuss in Chiang Mai. Okay, ladies and gentlemen, thank you very much for both speakers. Give valuable material and sharing best practice in Thailand, the hypertension crisis and maternal child health services. We hope we can learn together so we can apply in our clinical practice. Okay. I'm sorry for leading discussion. Bye. Thank you very much, Achan. See you.
Bye-bye. Assalamualaikum. Bye-bye.
Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Mr. Mardiono. And we want to thanks to Dr. Marsum that already accompanying our event. Thank you very much, Dr. Marsum. Ladies and gentlemen, this is the end of our session, and I want to welcome you to our second plenary session. In this session, we will serve you with 3 speakers. First is Dr. Emi Nurjasmi, Master of Health. Second is Prof. Nawi NG, MD, MPH, PhD. And the third is Professor Dr. Yutapon Vicianin. The session will be led by our second moderator, Mrs. Sri Widatiningsih, Master Midwifery. First of all, please kindly allow me to introduce our moderator. Mrs. Sri Widatiningsih, Master Midwifery. She is one of lecturer of Poltekkes Kemenkes Semarang, and her current position is head of Diploma 3 Midwifery Study Program of Magelang. She finished her 3rd diploma in nursing on 1995 from Sutopo Nursing Academy of Surabaya, East Java, and graduated from her master degree in midwifery on 2003 from Australian Catholic University, Melbourne, Australia. She's already taken international training and has a lot of publication and also books. Please welcome Mrs. Sri Widatiningsih, Master Midwifery. The time is all yours.
Okay. Thank you very much for the MC. Assalamualaikum warahmatullahi wabarakatuh. Peace be unto you all. Welcome back to the second session of our health conference on legal and ethical aspects of health services during the pandemic. My name is Sri Widatiningsih. I'm from Semarang Health Poltekkes, and I'm very excited to be the moderator during this session. Here we got, I would like to say my warm regard to you who come from overseas, and also my warmest regard to all of Indonesian participants. I hope you will be able to join until the end. For this session, we have 3 speakers, and all of the speakers are incredible experts. Before we go further, I would like to do a quick overview towards this session. At the beginning, we will have Dr. Emi Nurjasmi Kemenkes, the chairperson of Indonesian Midwives Association, who will be delivering the topic of legal aspects and ethics in midwifery education in Indonesia. Then followed by Professor Nawi NG, MD, MPH, PhD from University of Gothenburg, Sweden, with the topic of the impact of COVID-19 on health services for non-communicable disease. And subsequently, there will be Associate Professor Dr. Yutapon Vicianin. He's from Mahidol University, Thailand, and he will be presenting ethic and legal aspect of using health electronic data for research in industrial era 4.0. And there will be 30 minutes presentation for each speaker, and then followed by 10 minutes discussion. Okay, we would like to go with the first speakers. I would like to do a quick check. Dr. Emi Nurjasmi, have you joining us?
Yes, I'm ready.
Thank you, Dr. Emi. Okay. It's my pleasure to introduce Dr. Emi Nurjasmi Kemenkes to you. Okay, Dr. Emi Nurjasmi Kemenkes. She is the chairperson of the Indonesian Midwives Association and also the board member of ICM, International Confederation of Midwives, representative Southeast Asia. She's a senior midwifery lecturer in Jakarta 3 Health Poltekkes. And furthermore, Dr. Emi Nurjasmi Kemenkes also a senior midwife and pursue her doctorate in education management. And now she is with us and will be sharing about legal aspect and ethics in midwifery education in Indonesia. So please we welcome Dr. Emil Nuzazmi to present legal aspect and ethics in midwifery education in Indonesia. Okay, the floor is handed to you, Dr. Emil Nuzazmi.
Okay, thank you very much. Good morning, everyone, and Assalamualaikum warahmatullahi wabarakatuh. I would like to thanks to the Director of Health Polytechnic Semarang to invite me to join with this seminar. I think this is the very good opportunity for us to share information between us with other country. Okay, I would like to share my screen first. Did you see? Okay.
Yes.
Okay. Okay, thank you very much again. And also for my colleagues from Semarang Health Polytechnic, that all of there are my lovely friends, my colleagues, and who are actively also in improving midwifery association, midwifery education in the country. And also once again for the director or for the dean of the program study for midwifery education in Semarang Health Polytechnic. Also, I would like to share maybe in the general information about legal basis and ethics in midwifery practice and education. And specifically, we are talking about Indonesia, and also in previous, I would like to share the emphasize for the ICM competency standard also. Okay, we are now, midwifery is one of the oldest profession in the world. From the beginning of the human race, women have needed someone to assist them in the birthing process. We are acknowledged about this one, all people acknowledge. Okay, also that I would like to share also the ICM position statement. I think this statement also still used until now. Talking about midwifery is a profession in its own right, with a unique body of knowledge as well as shared knowledge with other health disciplines. Much of this knowledge is based on evidence. That is the result of research carried out evenly by midwives and others. And as such, it is extended or amended from time to time by the findings from new studies. I think that also we hope from this polytechnic, they can share the result of research could be improved, could be used to improve our profession in the country. How to build the profession, the struggle to be recognized as a true profession. Of course, we have the education. We have how to provide midwife from university base in higher education, a distinct service of practice and discipline, a research-based body of knowledge, autonomy, self-governance, and accountability. And also, we have to have a code of ethics, a list of code of ethics of midwife profession. And the association, our role, how to organize, to serve, and to speak for members and public welfare. From the ICM, we have 3 pillars, key pillars of midwifery profession. The pillars on strengthening midwifery as a profession. Of course, we have to talk about education, how to provide a midwife, a professional midwife, and also regulation, how to regulate profession in country and also the association, underpinned by competencies that we can see here. We must demand regulation, of course. We must have the strong education and support of midwife to ensure quality care for women, their newborn and families, and also their communities. The legal basis of midwifery profession, that specifically in Indonesia, that we have, I'm just talking about the regulation really relate with midwife, so many regulation consider about midwife and midwifery, but this is only some of regulation close relate to midwife. We have health workforce law number 36, 2014. In this law, that's divided the some categories of health professional in Indonesia. The medical categories consist of medical doctor, dentist, and also nursing categories, midwifery categories, nutritionist categories, public health categories, and others. That in health workforce laws that really clear the health professional in Indonesia, including nursing and midwifery. We have a separate profession in this law. And also we have specifically in midwifery law 2019, I think this is our long time effort how to establish midwifery law. And also we have nursing law, we have medical law, that we have medical law, nursing law, and midwifery law, that we close partnership between all health professionals in the country. Even though we have our own laws, in these own laws also regulate how to partnership, how to collaborate one provider to others. And also we have specific regulation, what we call the Health Ministerial Decree, number 2020, that established standard profession of midwife. It is also regulate for standard competencies and also standard of code of ethics. And licensing of practical midwife, midwifery care standard, and also ongoing process now for the educational ministerial degree standard, now ongoing process, the national standards in midwifery education. And it is some of our regulation that midwifery law, there is the profession standard. Okay, in midwifery law that regulate for all aspects of midwifery as a profession, starting from education, registration, licensing, midwifery practice, the rights and obligation, midwifery professional organization, utilizing, and also guidance and supervision. All aspects of midwifery as a profession regulate in midwifery law. The comprehensive regulation in this law. We are talking about the standard of midwifery education are one of the essential pillars to strengthen midwifery by preparing fully qualified midwives to provide high quality, evidence-based health services for women, newborn, and childbearing families. In the pillars, including updating competency standards for midwifery practice, midwifery education, midwifery regulation, and strong midwifery association relate with the ICM 3 pillars. The education standard were developed in tandem with the update of the competency standard for midwifery practice, as these competencies define the core content of any midwifery education programs. Of course, we develop our education program relate or following the midwife competency standard. The education standards were also completed in harmony with midwifery standards of practice and regulation. We have to provide qualified midwife quality midwife, competencies midwife to do their job in the health services. We are talking now about ethical theories. Ethical theories attempt to provide a system of principles and rules for resolving ethical dilemmas. Ethical theories conceive of fundamental belief about what is morally right or wrong and propose reasons for maintaining this belief. Ethical theories provide the base for professional codes of ethics. Now let me see, code of ethics for midwife. What is the code of ethics? A code of ethics is public declaration of the belief and values of profession and the members of that profession. This code makes public the goals, values, and morals of those who call themselves a midwife. A statement to the public about what the profession of midwifery defines as moral behavior for each practitioner. This is very important. And why we have a code? Why we need to have a code? A code of ethics acts as a specific identifying feature for a particular professional group, both for professionals themselves and for the public. In addition, now, in this situation, the need for an explicit code has become more urgent in recent years, as an accelerated pace of social and technological change has produced situations that demand an ethical response. The increased speed and frequency of global communication have made the development of a formal segment of shared belief and values vital as an agreed point of departure or common language for the professions worldwide. Now, there is no boundaries between countries. We are one. That's why the communication, the information really very fast come to us. The ICM International Code of Ethics for Midwives. We aim to improve the standard of care provided to women, babies, and families throughout the world through the development, education, and appropriate utilization of the professional midwife. In keeping with its aim of women's health and focus on the midwife, the ICM sets for the following code to guide the education, practice, and research of the midwife. 4 sections. This code acknowledges women as persons, seek justice for all people, and equity in access to healthcare, and is based on mutual relationships of respect, trust, and the dignity of all members association. It means that in ICM Code of Ethics, we divide it in 4 sections. Which section? Oh, I'm sorry. This is the section. The ICM International Code of Ethics for midwife. We have 4 sections in the ICM. The section we are talking about midwifery relationship, with our member, with our client, with all health professional and with whoever. And also practice of midwifery, how to do the practice based on standard, based on regulation, accountability, responsibility, and also the professional responsibility, and also advance of midwifery knowledge and practice. How we have to involve also to increase, to improve ourselves by continuing professional development, or maybe to involve how to improve our profession in the country. Okay, I come again. It is misorganized. Okay. Now we are talking also in the ICM, we have some standard for midwifery education. We have the organization and administration as the first standard. The host institutions support the philosophy, aims, and objective of the midwifery education programs. The host institution have to ensure the financial and policy support for the midwifery education program. The midwifery program has a design budget that meets program's need. I think that we have to have the information completely about the program, including also for the financial or the budget. And the midwifery faculty is self-governing and responsible for developing and leading the policies and curriculum of the midwifery education programs. I think this has been done in our country, specific for the Semarang Health Polytechnic. They are very active involved in strengthening and also development of midwifery education. The head of the midwifery program is qualified midwife teacher with experience in management and administration. The midwifery program takes into account national and international policies and standards to meet midwifery work opportunities from the ICF. And also midwifery faculty, the midwifery faculty includes predominantly midwife, teachers, and clinical preceptor who work with experts from other disciplines as needed. Predominantly midwife and also could be from other discipline, depend on our needed. The midwife teacher has formal preparation in midwifery, demonstrate competency in midwifery practice, holds a current license and registration of legal recognition to practice midwifery, has formal preparation for teaching, maintains competencies in midwifery practice and education. This is the requirement as a midwife teacher. The midwife clinical preceptor, also clinical teacher, that so many requirement for midwifery preceptor, for midwife preceptor or clinical instructor, is qualified according to the ICM definition of midwife, demonstrate competencies in midwifery practice, maintains competencies in midwifery practice and clinical education, holds a current license, has formal preparation for clinical teaching. Individuals from other disciplines who teach in midwifery program are competent in the content they teach. Also, we can involve other profession in a practical field as a mentor, as a preceptor, depend on needed, that what I mentioned before. Midwife teacher provide education, support, and supervision of individuals. Midwife teachers and midwife clinical preceptor work together. The ratio of students to teachers and clinical preceptors also informed by and the effectiveness of midwifery faculty member is assessed on a regular basis following an established process. The qualification and responsibility of midwifery teacher, the major of teacher within a midwifery program should be midwife, the majoring, but also could involve other profession. I think that's we need other discipline involved in our program, like OB/GYN, pediatrician, public health, or maybe nurses, it depends on. In order to do this, it is expected that the midwifery teacher will be competent in all areas of midwifery practice and specifically up to date in areas they are teaching. I think it is very important in our situation in Indonesia that we lack in this part. That's why we are trying how to improve, how to encourage them to maintain their competencies. I think there is a teacher, including me, also be legally recognized to practice as a midwife in the country, have formal preparation for teaching, demonstrate a commitment to lifelong learning and maintaining their midwifery theoretical and practical competencies. The core responsibilities of midwifery teacher and preceptor, teaching and practicing in accord with professional ethics and standard. How to compliant, not just to competent in the skills, but also compliance to the regulation, to the standard. Promoting evidence-based midwifery practice, understanding one's own values and beliefs related to teaching and learning, providing a safe, supportive environment, safety care, patient safety, and also learning based on mutual trust and respect, and maintaining confidentiality of student concerns and record. Using a variety of teaching methods, directly supervising students in practical setting. Directly supervising, it means that we have to regulate, we have a schedule to supervising our student in practical field. Being open to conflicting ideas and opinions. We have to open to receive others' opinion, others' recommendation, assisting learner to connect current information to broader concepts, and collaborating with other professionals and members of the healthcare team, making learning fun. I think this is also, we have to consider for how to develop, how to provide making learning fun. I think as a teacher, they know how to do this. There is the section in ICM competencies talking about midwifery relationship. Oh, I already mentioned, I already read this one, sorry. Okay, now we are come to Indonesian Midwife Code of Ethics. A professionals and accountability is the focus. This principle focus on professional responsibility and accountability, personal and professional integrity and advocacy. It also refers to professional boundaries, conscience choose that we have many health profession, we have our own competencies, our own authorities. We know better who we are. Okay. In Indonesian Midwife Code of Ethics that we have also some section. And Midwife Code of Ethics in Indonesia, a set of norms agreed upon by the Indonesian Midwife Association Professional Services, increase the dedication of members and improve the quality of professional services. When we develop our own Indonesian Midwife Code of Ethics, also we follow the ICM standards as our references, and we adapting to our country, not adapting, because maybe some part it's not related with our country, or maybe many section in this country that there is as our references, ICM Code of Ethics, and we develop our own code of ethics based on our country situation. Midwife ethics that we are talking, ethical, term, values, moral, concept or ideal that give meaning to the life and provide framework for decisions and action. Ethical code, a written list of profession values plus standard of conduct. Statement of etiquette describe expected professional behaviors established in ethical code as a guideline for good and correct behavior, namely appropriate action, which must be carried out by midwife in accordance with the moral principles of the midwife profession. This code of ethics is used as a guide for members of the Indonesian Midwife Association in carrying out the professional services in accordance with professional standard expertise and applicable regulation. Compliant, based on standard, evidence-based. This is very important. Now we have some section that the first section that we are talking about, a general obligation of Indonesian midwife. I think so many statements here. Midwives must uphold, love, and practice the midwife professional The midwife must carry out their professional duties according to the midwife professional ethical standard. Midwife in carrying out their professional duties uphold human dignity and are not influenced by consideration of personal and group benefits that result in the loss of professional freedom. Midwife in carrying out their duties always put the client interest first. Client-centered care, women-centered care. Midwife always create a conducive atmosphere. Midwives are not allowed to disseminate and apply any new inventions, methods, and or techniques that have not been verified, that should be evidence-based, not trying, but evidence-based, and also state as a standard and not trying anything in practical or midwifery care. In carrying out their duties, a midwife must prioritize the interests of the community. Midwife in carrying out their duties can work independently, collaboratively, and or refer. Of course, now we cannot do by ourselves one individual, but could be partnership with other health profession or maybe with other whoever will need it, yeah, in practical midwife. We have to collaborate to others, to whoever we need. Midwife in carrying out their profession duties must be fair, honest, non-discriminatory, and do not judge clients. That we call now, we have to give care by approaching the RCM, respective care in midwifery care. In midwifery, yeah, RMC, yeah, respective midwifery care. The liability of the midwife to the client, midwife must always understand and carry out their humanitarian obligation, protect the life and human being. Midwife respect human rights from the time they are in the womb, from the womb, and are prohibited from taking action that violate the laws and regulation. Respectful midwifery care. Oh, now I remember. Midwife use multidisciplinary. Knowledge and to support their skill for the benefit of client. Midwives are obligated to respect the right of clients. The midwife is obligated to keep everything she knows confidentially. Midwives are required to provide emergency assistance. That what I would like to mention again, how the approaching of midwifery care is we use the respectful midwifery care. We have to respect to our client, their values, the social cultural values that we have to respect. Obligation of the midwife to the duty, midwife always provide quality care. Midwife maintain the confidentiality of client information. Midwife providing services to community must respect local culturally diversity, because we have so many cultural systems in the country. We have more than 17,000 islands in the country, so many cultural diversity. Midwife use the science and technology, evidence-based professional knowledge to ensure safe practice in all healthcare settings, environments, and culture. That we are talking about the patient safety, safe care. Midwife in carrying out their duties must obtain approval from the client and or their families for the actions to be taken after providing clear information and documenting midwifery care in accordance with standard. This is the obligation of the midwife to partners and other health personnel. Midwife must establish good relationship, good collaboration with their colleagues and other health professionals to create a harmonious working atmosphere. We have been done, but we have to improve. Yeah, obligation of the midwife to the profession. Midwife seek the well-being of mother and baby, respect and support physiological process. Midwife must maintain a good name and uphold the image of the profession and provide quality services to the community. We have to improve our profession status and also the image of a midwife as a professional. Midwife must always develop themselves and improve their professional abilities to accordance with the development of science and technology. Midwife always participate in research activities and other scientific activities that can improve the quality and image of the profession. The midwife obligation to serve also, we have the obligation.
Dr. Amy, you still have 5 minutes to go.
Okay.
Thank you.
Yeah, I think just 2 or 3 slides more. A midwife must maintain their own health in order to carry out their professional duties properly and correctly. Now, really relate in this situation. Yeah, we have to protect ourselves and we have to protect our client. Midwife always maintain and improve knowledge, skills, and in accordance with the development of science and technology. Midwife in carrying out their duties must look good in accordance with professional duties, not good looking. I don't mean good looking, but professional. Yeah. A midwife must maintain their dignity as a professional midwife. The obligation, this is the last, the obligation of the midwife to the government and the nation. This section, it's not written in the ICM, but in our country that we have one obligation because there is the situation in our country, also other health professional state also for this obligation. A midwife in carrying out their duties always carry out government policies in the health sector, especially in maternal and child health services, reproductive health, and family planning. Midwife participate in the development of government policies to improve the quality of health services, especially maternal and child health services, reproductive health, and family planning. Take-home message, professional values that we have to remember, we have to consider, we have to implement in implement our care, midwifery care. Midwives are expected to show high standards of professional behavior. Midwives are professionally responsible and accountable for their practice, attitudes, and actions, including inactions and omissions. Not all we can do it. We have to refer to the regulation. Midwife recognize the relationship between professional responsibility and accountability and their professional integrity. Midwife advocate for patients' right, respectful midwifery care. Midwife recognize their role in the appropriate management of healthcare resources. We are, as a professional, we have to recognize who we are, what we can do, what we cannot do. I think that we have to have our understanding how to do our profession in practical services. I think this is the last slide. Thank you so much.
Thank you, Amy Nurjasmi Kemenkes. That was a wonderful presentation. Thank you. Now we have a new insight about legal aspect and ethics in midwifery education in Indonesia that has been compliant with the standards and regulation and also fulfill the ethical aspects internationally. And now is the time for discussion. Let me check the chat room. Okay. Okay, there's one question from Nur. Sorry, Raharni from Raharni Rosdiati. Okay, good morning, Mom and Minu Jasmine. Glad to see you here. Make me more proud as a midwife. First, let me introduce myself. My name is Raharni. I'm a new student from Postgraduate of Midwifery. I want to know about your opinion about the ethics of midwife students nowadays. And as a student of Postgraduate, please give an important message for us to face the profession world, after we graduate. Thank you so much. Okay, Dr. Amy, you can address the question.
Yeah. Thank you so much for the good question. I think the first one that the ethic of the student, I think the general ethics, you have to do the general ethics, and as student, how to follow the teaching learning process, how to follow also the requirement of the institution education, and also the general ethics as a profession, as a human. And also you have to starting to understand the professional ethic as a midwife, because you become a midwife and starting from study, you know better who are a midwife, and also not you just only know the definition of midwife. Of course, you have to know completely about midwife, not just definition, but also the scope of work, the competencies, and also the code of ethics as a professional midwife. I think also from the postgraduate student, graduate student, or bachelor degree student, or even though diploma student, we have the same student ethic. We have the same, what we call the student requirement when they are study in the program, whatever the program. Okay.
I think what you said just clearly explain what she wants to know. Okay, thank you for addressing the question. So for the next question is from Hanifatul Rashida. She is asking about, is there any ethics between EB and breast milk substitutes?
Pardon?
So she wanted to know whether there is any ethic issue, maybe ethic issues between EB, Midwives Association of Indonesia, and breast milk substitute PASI, maybe we said pengganti susu ibu. Sorry,
exclusive breastfeeding. Yes, of course.
Maybe what is the rules of EB to ban the breast milk substitute? Okay, thank you.
Yeah. In our practice, that we have to protect our client. Our client, not just mother, and also her babies, her families. And how to protect them, how to protect a baby. They have to take the breastfeeding, and also we have the code of WHO code for the exclusive breastfeeding. Also, we use this code, we use this regulation also in our country, and of course in our profession. We have the ethic, we have the code of ethic, how to protect babies. They deserve to get the breastfeeding milk. They deserve to get the breastfeeding milk from their mothers. I think this clearly you can see in detail in our regulation, in our standard, how to protect client, not only mother, but also baby is our clients. All babies, they deserve to get the mother milk. Okay?
Okay, that's wonderful answer. Okay, we still got one other question from Nur Hadia. Oh, that is, we missed this question. Okay,
How
sorry.
many minutes more?
Good morning, ma'am, for Dr. Emi Nur Jasmi. And because my name is Nur Hadia, I am a new student from Postgraduate of Midwifery. I'm sorry if this is out of the topic. I want to ask about if there is a girl who is delivered by her mother and wants to have an abortion. She is still 15 years old and still want to continue her school. As we know, abortion is not allowed except there is an indication in medic. What we call it a moral issue or a moral dilemma. What is the difference between these two? Is this still allowed in midwife? Is this still allowed if the midwife agreed to give an abortion in this case? Thank you. Okay, so this is about unwanted pregnancy in teenager.
Yeah.
Whether midwife approve for the abortion or not. Thank you.
Okay, actually your question already answered by yourself. I know. In our country, abortion is not allowed based on the regulation. And also in our profession, our competencies is not including for the abortion. We in our competencies that we have the post-abortion care, not how to pull out the babies from the womb. No, that if we have client, teenager come to us, of course, we have to serve them. We give the information, education, and counseling. And because there is, when they would like to do the abortion, it's not included in our competencies and also in our authorities. We collaborate to other professions. Even though only for the counseling, maybe we are not experts in counseling itself. We have to collaborate to the clinical psychology, to the counselor, and then also we have to collaborate to other profession. We have to refer to other profession. Could be to the psychology, clinical psychologists, or to the OBGYN, or whatever. Because once again, we are not talking about allow or not allow for the abortion. But we are talking about abortion is not including in midwife competencies. In our competencies, we just keep for the post-abortion care. Yeah, we have to collaborate. Thank you.
That's the right answer. Because midwife ban the abortion, yeah? But we give the access for the client to maybe doing the consultation or other things that can be solve the problem. Okay, lovely. So there's another question.
Wow. How many minutes more?
Amy, I am Veronica from Postgraduate Midwifery. Can a midwife do ultrasound to a patient who SK as usual? This is are this the job of the SPOK, or can we do it about the ultrasound? Okay, thank you.
Okay, I think there is a good question. And also I'm understanding for these issues because right now we can see maybe some of midwives use the USGs, ultrasonographies. You have to see midwife competencies. Comprehensive, you have to see. They are completely written in our competencies. For the USG, we cannot do by ourselves alone. In our list of competencies, there is USG activities, but the level of competencies, not 4th level. We cannot do independently by ourselves, but I'm not sure. Maybe for the USG in our competency for the professional program, level 3 or level 2. Level 3, we can do it, but in a team under supervision. I'm not sure, level 2 or level 3. If level 3, we can do under supervision in a team. We are together with other health professionals and we can do it, but not by ourselves. Not but our own authority. Yeah, I think in this issue that very clear. Please see in the list of competencies. We cannot do USG by ourselves, but we can do it in a team because in the list of competencies, the achievement of USG's competencies, I think level 3 or level 2. I'm not sure, sorry. You can see. If level 2, we know the USG. We learn about USG, but at the end, we cannot do only by ourselves. It's not our authority, even though also for the general physician, yeah, they have the competencies. I think it's not the 4th level. Yeah. Okay. We have to work together to other profession. We cannot do USG by ourselves alone. In our authority, we can do it in a team.
Okay. Good answer. Okay. So I think it's clear now for us that yes, we can do the USG.
That's why my message, how to
solely
comply. How to comply.
Okay, so still have another question from Amardia. Assalamualaikum Ibu Emi Nudasmi. I'm Amardia. I'm currently a midwifery graduate student. I have a question almost the same as the other maybe. In the context of midwifery ethics and morale, there are still private midwives who support the formula milk or baby milk and many others. Is this going to violate the ethics and morale of midwifery, given the fact that we as midwives should support the government program on exclusive breast milk? What is your opinion in that? Thank you.
Yeah, I think in the first question also the same. Yeah, the same question. But now in the reality, some of our colleagues, they still promote for the formula, you mean? Yeah? Yes?
Yes.
Yes.
Formula.
And how?
Yes, so breast milk, Ibu. This formula. Formula. Such as
yes.
yes.
Yes, formula. I think in our etiquette, in our code of ethics, that already done, already written. Also, WSO code, also the government code, the government regulation. Also, we put also in our profession standard. If some of our colleagues still do this, still promote the formula milk, I think that is our responsibility. How to inform them, how to encourage them. I think that we have to supervise, we have to evaluate, and we have to, we have to remind our colleagues, this is not the right best. Yeah, that's our responsibility from association, I think. From the central, we have to talk to our colleagues from the provincial board and also for the kabupaten kota, yeah, for district board. And we have to talk, we have to remind our colleagues. Okay.
Yeah.
I think based on this situation, based on this webinar, also we always inform our member from all country, and I think they follow some information based on like this event. This is part of our improve our reminding our colleagues how to comply to the standard of ethic, the standard of practice, and comply to the regulation. This is very important. This our all responsibility, including teachers, including the board association. Thank you.
Okay, excellent. So I think all of us love to talk with Ibu Emi. So not only midwives, but also another participant. Okay, I will give one chance for the participant to say or to address the question directly to Dr. Emi by Zoom platform. You can just unmute yourself and ask the question directly to Dr. Emi. Okay, this is only one chance. Okay, who will be the lucky one? Is there any of the participants who want to ask directly to Dr. Emi? You only got 280 participants. So who want to ask directly to?
I'm sorry, I have limited time because I have another webinar.
Okay,
Yeah,
may
sorry.
I ask?
Yeah.
Can I have a question?
Take this chance, but thank you, Dr. Emi, for informing us. Okay, I think that was the. Sorry. Yeah, I think that was the end of our discussion with Dr. Emi Nurjasmi and for Dr. Emi, could you please hang on a minute? We want to show the certificate of appreciation from the committee to you.
Thank you.
Here it is. Congratulations and thank you for valuable sharing with us. The certificates will be sent to the speakers shortly by email. On behalf of the committee, I would like to say thank you very much for spending your time sharing with us, Dr. Emi. It's our pleasure if you could continue joining us, but if you still have another business to be done, then it will be fine also. Thank you so much and we appreciate for you. Thank you.
Okay, thank you to all of you, and also the honorable of expertise speaker from other country. I'm sorry I did not call yet. I think thank you for you come to this webinar and share information to us. I think very important to us is part of collaboration with us around the country in the world. Thank you so much and congratulations.
Thank you. Big applause to Dr. Eminur Jasbi Kemenkes.
Okay,
thank you.
Assalamualaikum warahmatullahi wabarakatuh.
Okay, thanks. And now we will go to the next speaker. I would like to do a quick check. We will be having Professor Nawi NG, MD, MPH, PhD. Let me do a quick check of his presence in our conference. Professor Nawi, have you joining us? Oh, okay. So, okay, not joined yet. Okay, while we are waiting for the professor to join with us, we will show you the video of the study program of the postgraduate study program of Semarang Poltekkes
di Indonesia. Harmonisasi sejarah dan akulturasi budaya yang selalu diiringi dengan merupakan ibu kota Provinsi Jawa Tengah. Politeknik Kesehatan Kementerian Kesehatan Semarang merupakan salah satu politeknik kesehatan yang berada di Provinsi Jawa Tengah yang berdiri sejak tahun 2001. Program Pasca Sarjana Politeknik Kesehatan Kementerian Kesehatan Semarang diawali pada tahun 2015. Politeknik Kesehatan Kementerian Kesehatan Semarang dipercaya sebagai satu-satunya politeknik kesehatan di Indonesia yang memiliki program pasca sarjana Magister Terapan Kesehatan.
Visi program pasca sarjana Poltekkes Kemenkes Semarang adalah menjadi institusi penyelenggara program pasca sarjana Magister Sains Terapan Kesehatan berbasis kearifan lokal dan diakui di tingkat nasional dan internasional pada tahun 2025. Sedangkan misi program pasca sarjana adalah satu, menyelenggarakan pendidikan pasca sarjana yang menghasilkan lulusan kompeten dan berbudi pekerti luhur untuk memenuhi kebutuhan pelayanan kesehatan di tingkat nasional dan internasional. Kedua, menghasilkan karya penelitian kesehatan terapan dan berkontribusi nyata di dalam pembangunan kesehatan. Dan misi ketiga adalah menghasilkan karya pengabdian masyarakat berbasis hasil penelitian dan permasalahan kesehatan. Dan yang misi keempat adalah mengembangkan kemitraan dengan berbagai institusi pemerintah dan swasta di tingkat nasional maupun internasional untuk meningkatkan kapasitas lembaga di dalam pengembangan ilmu pengetahuan dan teknologi.
Okay, and now we will go to the next speaker, Professor Nawi NG, MD, MPH, PhD. a professor of global health. Let me do a quick check of his presence in our conference. Okay, Professor Nawi, are you joining us? Hello, Professor Nawi?
Yes, good afternoon. Can you hear me?
Okay. Yeah. Okay, thank you. Okay, I'm honored to introduce him to you. Here we got Professor Nawi NG, MD and PhD. Professor Nawi got his medical doctor from Gajah Mada University. Then he finished his MPH and PhD from Umeå University, Sweden. He is a professor of global health at University of Gothenburg, Sweden. He is also a guest professor of epidemiology and global health at Umeå University, Sweden. His research focuses on epidemiology and of non-communicable diseases and aging, disability, and quality of life among older people in Sweden and in low and middle income countries in collaboration with the WHO and the INTEP network. He's leading several international projects and also published 140 papers in peer-reviewed international journals, which cannot be mentioned one by one. He will be delivering the topic of the impact of COVID-19 on health services for non-communicable disease. So, ladies and gentlemen, here he is, Professor Nawi NG, MD and PhD. Professor, I handed the floor to you.
Thank you very much. Good afternoon, everyone. I would like to thank the Poltekkes Kemenkes Semarang for inviting me to speak in this conference, the second International Health Conference, today on 16th of November. So I'm going to talk a bit about the impact of COVID-19 on health services for non-communicable diseases. I hope you see the full screen of my title page. Ibu moderator, ini apa sudah melihat layar saya yang penuh ya?
Okay, you can go on. Thank you.
Okay, thank you very much. So I still remember very well, my last international trip was to Indonesia back in December 2019. On the flight back to Sweden, I bought this magazine and I read it on the plane. It seems that the outlook of 2020 was quite bright. The economists by then predict that there were a few political events in the world, the development of artificial intelligence, the Tokyo Olympic back in 2020, and the Mars explorations. Of course, climate change as well as recessions was problematic also, but it was not the main problem that was predicted for 2020. And by then, we of course did not see COVID-19. But suddenly, on the 30th of December 2019, we got the news that there were severe pneumonia-like symptoms or syndrome in China. And soon, within a few days, by the 22nd of January, there were already 509 cases spread in several provinces in China. And we are now 615 days into the pandemic since the WHO declared COVID-19 as a pandemic back in 11th of March 2020. The world have seen at least 3 waves of COVID-19 pandemic, and maybe the 4th wave is on its way in some of the countries. We see cases are still quite high in the US, United Kingdom, Russia, Turkey, and Germany. And to date, there are in total 253 million cases until yesterday when I produced these slides. Over 5.1 million deaths already due to COVID-19. But the good side of the news is that we have almost 7.5 billion of COVID-19 vaccines being distributed to the whole population in the world. So when we talk about COVID-19, this is a graph which is widely shown or widely discussed in the beginning of the pandemic. Even before the pandemic, many hospitals, especially hospitals in low-income setting, they had operated close to their capacity lines. When the pandemic occurs, there were increasing number of cases that need treatment. The health systems was overloaded in many settings, and therefore healthcare system collapsed. We still remember the rise of the pandemic in Indonesia a few months back, where almost all of the hospitals in most part of Indonesia were occupied by COVID-19 patients. So the consequences of the collapsed health system is health system deliver poorer quality of care, and which could lead to higher rate of mortality and disability of patients attending the hospital. So what were the responses from health system? So government in many parts of the world try to slow the spread to reduce the burden of COVID-19 pandemic to the health system. So we know this term flattening the curve. So how do we do that? We either try to reduce the number of new cases, at the same time try to increase the healthcare capacity to take care for COVID-19 patients. So we increase the capacity line from the lower parts to the higher parts. So the problem with pandemic of unprecedented scale as such is that many local, national, regional, and global governments, they are lacking of capacity to prepare for the pandemic and to respond to the pandemic. Collapse of health services has significant impact for health of the populations, especially among the vulnerable population. We are talking about children, older people, those with chronic diseases, and minority groups. And the COVID-19 pandemic has revealed the large inequality in health systems. There are so much differences in the capacity of health systems across the world to respond to the COVID-19 pandemic. And the WHO in 2021 conducted a survey to all countries in the world. 94% of the responding countries, a total of 135 countries in the world, mentioned that they had experienced some disruptions of essential health services. 9% of those countries reported up to almost 100%, between 75 to 100% disruption of the services. 25% reported 50 to 74% disruptions. Only in 6% of the countries, the WHO did not observe any disruption of essential health services. So what kind of health services are we talking about? Of course, different areas. For example, program to handle neglected tropical diseases like malaria, dengue, immunization program, non-communicable disease program, or for example, program to handle mental neurological substance use disorder. But also important are programs for reproductive, maternal, and newborn health. But I'd like to pinpoint on two specific programs which were disrupted quite significantly in the world. 37% of all the world countries reported that they had some disruption in non-communicable diseases, essential health services. And 37% also reported that there has disruption in provision of immunizations, particularly for young children. So today we are going to focus on non-communicable diseases. So when we talk about non-communicable diseases, we are mainly talking about 4 different diseases. We are talking about cardiovascular diseases. We are talking about diabetes, stroke, as well as cancer. So those 4 diseases are 4 leading causes of death in the world. So in the same survey, WHO shows that 69% of the countries in the world reported that they had some disruption in NCD or non-communicable diseases diagnosis and treatment. So for example, they had problem to diagnose diabetes patient or to treat diabetes or cancer or stroke patients. And among these 69%, 5% reported that they had severe disruptions. So in 5% of the countries, for example, cancer patient could not get any treatment. Hypertensive patient could not get their medications. 61% of the countries in the world reported problems to treat mental health disorder. So about 105 countries in the world. So 3% among of them reported severe disruption. Imagine people with mental health problem could not get their treatments in some of these countries. Cancer diagnosis and treatment was also disrupted in 55% of the countries in the world. So at the beginning of the pandemic in 2020, WHO conducted an initial survey quite similar to the one which I saw on the previous slides. But this was at the beginning of the pandemic. 75% of the countries reported that they had one or more disruption of 8 essential services for non-communicable diseases. So now we are looking at services for non-communicable diseases. So about 50% of the countries in the world reported that had problem in hypertension management. About 50% also reported problem in diabetic patient management. Over 60% countries in the world reported disruption in rehabilitation services. Imagine a stroke patient who need rehabilitation services could not get their rehabilitations in 60% of countries in the world. And if we look at the red color, in 10% of the countries, they reported complete disruptions. So for example, rehabilitation clinics were closed completely due to COVID-19. So we are also looking at disruption in cancer treatment at the beginning of the pandemic. 40% of the world countries reported some disruptions. But what was surprising, of course, though expected, is disruptions on cardiovascular disease emergency. So in 30% of the countries in the world, patients who have heart attack, for example, when they go to the hospital were full with COVID patients and they could not get intensive care units. So those are such emergency that I'm referring to. So the problem with non-communicable disease patients is that they need interaction with healthcare system because chronic diseases or non-communicable diseases are long-term diseases that needs long-term monitoring, long-term treatments, and long-term interactions with a healthcare system. Imagine in COVID-19 pandemic, many of these services have closed because the health system has geared towards addressing the acute problem of COVID-19. And what could this lead to? Severe disability among patients, premature death, for example, people with heart attack, they could not get placed at the hospital and they die because of their heart attack, not because of COVID-19. And of course, billions of dollars in economic loss every year, especially in the poor setting. So if we look into more details, according to this today's topics on non-communicable diseases, we look globally, for example. This survey was done in the beginning of the pandemic back in 2020. So there are different items which are related to NCD inpatient services. But I'd just like to point to a few. For example, over 60% of the world countries, 60% of the countries in the world reported that there have been decrease in inpatient volume due to cancellation of elective care. So there has been a lot of cancellation of elective operations or elective care because of COVID-19. And there also has been reported almost 30% of the countries in the world reported that they have insufficient PPE. And maybe we have seen this also in Indonesian setting. But I'd like to pinpoint also these patterns holds in many low-income settings. So almost 60% of the low-income countries, they reported cancellation of elective care, orthopedic operation, for example, heart valve replacements, diabetes treatments, and so on. And here we see the patterns in different parts of the world, in low middle income country, upper middle income country, as well as in high income countries. I just want to pinpoint on some discrepancies. So almost everywhere in the world, we saw that governments or health authorities have canceled elective care. This is understandable because they need their human resources and all these infrastructure to take care of COVID-19 patients. But what we see is there's such a big discrepancy in terms of supply of PPE. In low middle income countries, almost over 50% of poor income countries reported that they have insufficient PPE, but less than 20% of those high income countries. So this is what we refer to inequalities in terms of infrastructure or capacity to handle the pandemic. The last thing I'd like to pinpoint is the stock of medicines. Such a big discrepancy that over 40% of the poor income countries reported disruption, while less than 10% of the high income countries. So again, this pinpoint that the COVID-19 pandemic has affected non-communicable disease services globally. If we look at the global picture, it seems that almost all countries in the world have somehow reported some disruptions in their NCD services. But when we break down the numbers by different regions or different types of country, we see such big discrepancy between low income and high income settings. And the final slide on this chart, this shows the percentage of country reporting that government policy restricting access to outpatient NCD services. Globally, we see that about 40% of the countries reported that their outpatient NCD service were open during the pandemic, in the first wave of the pandemic. So about 55% reported that the outpatient services were open with some limited access and staff alternate locations with different modes. Okay. Less than 5% of the countries reported that they have closed the outpatient NCD services completely. But when we look at the countries based on their COVID-19 transmission status, in countries where there were no cases, of course nowadays there are only very few countries with no cases, but by then in the beginning of the pandemic last year, there were some. So in countries with no cases, almost 60% of the countries reported that they still have their outpatients and services for NCD patient open, as compared to only less than 40% for countries with community transmissions. So here we see that COVID-19 has somehow impacted the services of NCD patients, including the outpatient services. Yeah, just to pinpoint when there were cluster cases or community spread of COVID-19, countries reported that they have closed their NCD service completely. So what's the problem with COVID-19 and NCD? We know the term syndemic. Syndemic is a term which was developed by Mario Singer back in 1990 to understand the relationship between HIV/AIDS, substance abuse, and violence. So the term syndemic exists, or a syndemic exists, when risk factor or comorbidities are intertwined, interactive, and maybe cumulative, at firstly exacerbating the disease burden and additively increasing their negative effect. So we look at, for example, three different problems: COVID-19, chronic non-communicable diseases, and social determinants of health. These three different health problems, they could somehow intertwine We have heard a lot that people with comorbidities like hypertension and diabetes, they are at higher risk to get COVID-19. Poor people is one part of social determinant of health, also increase the propensity of a person or a population to get COVID-19. So the world is facing huge problem now because these three problems somehow intertwine with each other. And as a consequence, the disease burden could be exacerbated. For example, in low-income setting where hygiene could not be ensured, there's no water to wash hands, that's social determinant of health, then we see higher number of COVID-19 cases. So I'll show a few slides which show this syndemic of these three problems. This slide shows racial disparities. On the x-axis, we have different racial groups in the US, Black, Latino, other, and white. And on the y-axis, it shows the proportion of people in each group reporting housing insecurity, food insecurity, financial insecurity, as well as employment insecurity due to COVID-19. So these are only due to COVID-19. They were asked if COVID-19 has somehow affected their housing security, food insecurity, and so on. So we can look at these patterns. It's a very clear trend that there are certain ethnic groups which suffer most due to COVID-19. And I have highlights, for example, the Black people in the United States, they have reported higher proportions of insecurity due to COVID-19. And the results were statistically significant. The asterisk on the top of the dots represents a p-value in statistical analysis. So when we look at educational groups, we also see such discrepancy. People who have the highest education lower than high school, they tend to have or reported higher prevalence of insecurity in any of these dimensions. So COVID-19 has somehow led to deepen health or socioeconomic inequality across different groups, across different race groups, across different educational groups. And we know that COVID-19 impacted non-communicable diseases. And non-communicable diseases is also impacted by socioeconomic. So this is what we call as a Lorentz curve. I'll try to explain this. On the left here, we see the Lorentz curve for urban area, and on the right, we have Lorentz curve for rural area. So how do we interpret this curve? On the x-axis, we have the population ranked by their socioeconomic status. Okay, so if we have, for example, 1,000 households in an area, and we measure their socioeconomic status for each of these 1,000 households, then we rank them based on their socioeconomic status. So those who were at 0 to 20%, this would be the 20% poorest socioeconomic household. The next 20% poor socioeconomic household, a household with the socioeconomic status. And then on the top here, we have the 20% household with the highest socioeconomic status. So on the x-axis, again, these are all the population ranked by their economic status. So the bottom 20% represent the bottom 20% poorest, and the top 20% represent the 20% richest. So on the y-axis here, we also rank the cumulative proportion of the health variable, any health variable. Okay. So if there is equality, okay, if there is equality, then we will see the Lorentz curve will be a straight line like this. So let me take this point. This represents 20% of the poorest population. If 20% of the poorest population account for 20% of the disease burden, and if 40% of the poorest population account for 40% of the disease burden, and if 60% of the poorest population account for 60% of the disease burden, then we say that there is no inequality. Okay, the burden is equally distributed across socioeconomic group, because 40% of the poorest will have the 40% of the disease, 80% of the poorest will have 80% of the disease. Okay, so that is what we refer to line of equality in Lorentz curve. But it seems that hypertension, diabetes, and obesity do not follow the line of inequality. They are below the line of equality, right? So these three lines, they are below the line of equality. So how do we interpret these three lines? How do we interpret these three lines? So let me just point on this number, these dots. This is for hypertension. Okay, 80%, let's assume this is 80%, it's a bit to the left. 80% of the poorest population accounted for less than 50% of the disease burden. Okay, here 60% of the poorest population accounted for only 20% of the disease burden. This means that most of the disease burden, they were among the rich people, right? If the lines falls below the line of equality, that means that these diseases concentrate more among the rich people. Why do we say so? Let me try one more time. I'll point at obesity. 80% of the world poorest population or maybe here in Bangladesh, 80% of the poorest population in Bangladesh accounted for only 20% of obesity. So if 80% of the poor only has 20% of the disease burden, that means that the remaining 20% of the rich has the remaining 80% of the burden. Therefore, we see quite a steep slope in this line from 80% to 100%. Okay, try to sum this up. Non-communicable diseases in urban area concentrate among the rich. But when we look at in the rural area, we see a different pattern. In Bangladesh, non-communicable diseases concentrate among the poor, particularly hypertension and diabetes, but obesity concentrate among the rich. Okay, so this is what we refer to as socioeconomic inequality of non-communicable diseases. One of my PhD students have done similar study in Vietnam, showed quite different patterns also, and also one in Indonesia. So we have a problem here. We have problem in terms of socioeconomic inequality in non-communicable diseases, socioeconomic inequality in COVID-19. And not only the diseases shows inequality, but we also see risk factor related to diseases also show inequality. I'm sorry, this is a bit crowded, but if we focus on the top left graph, this shows the Lorentz curve for high blood pressure or hypertension in urban and in rural area. Okay, so if we look at this picture, this is from sub-Saharan Africa countries among women. So among women in sub-Saharan African countries, hypertension focus more on rich women. Obesity focus more on rich women in the rural area. Okay, but tobacco use focus more on poor women. So having more economic stability increase their chance to get obesity and hypertension in rural sub-Saharan Africa, but being poor increase their chance to have to adapt a tobacco use behavior, so in urban and rural. So here we see there's no differences. Here is one example for alcohol consumptions. It fits the line of equality, which means that this is quite a bad news actually. It means that everyone drinks alcohol. Yeah, okay, so there's no differences in alcohol's drinking patterns. Either they are poor or either they are rich, everyone drinks. And this is quite troublesome, I would say. So the problem with non-communicable diseases, especially now with COVID-19, is non-communicable diseases tend to cluster together. If people have hypertension, most possibly they also have diabetes. Most possibly later on they will have heart diseases and stroke. So this is a condition which we refer to multimorbidity. So it's a coexistence or two or more chronic conditions in the same individual. And of course, this is a serious problem because we know that multimorbidity or comorbidity is a risk factor for for COVID-19. So it predicts deaths among COVID-19 patients. So the presence of two or more conditions or multimorbidity among COVID-19 patients increase the risk of mortality by almost 10 times. So how is the situation in Indonesia? In the next few slides, I'm going to show some results from Indonesia. This is the situation in Indonesia back in 2019. What were the leading causes of death in Indonesia? What do we die of? So the top 4 leading causes of death in Indonesia back in 2019 were stroke, ischemic heart diseases, diabetes, hepatic cirrhosis, tuberculosis, and chronic obstructive pulmonary diseases. So those were the top 6 causes of death back in 2019, 2 years ago in Indonesia. Of course, we still have problem with infectious diseases like tuberculosis, diarrhea in certain part of Indonesia. But tuberculosis and diarrhea, if we look at the changes between 2009 to 2019, in 10 years' time, the number of deaths related to tuberculosis and diarrhea has decreased by almost 1/4. So 26% for tuberculosis, 21% for diarrhea. But look at stroke. It has increased in the same periods by almost 26%. Look at ischemic heart disease, 28%. But surprisingly, diabetes has increased by 50%. So only in 10 years periods, those leading non-communicable diseases has increased in its burden significantly in Indonesia. And of course, this should become our concern. So I'll show a few results from a study that we have conducted in Indonesia based on the IFLS analysis. So IFLS stands for Indonesian Family Life Survey. It's an open access data which everyone in the world can have access to, including all the participants in these seminars. So I'll strongly urge if you are interested to do some health-related analysis, visit the IFLS website, try to understand what it is, and download the data. So it could be used for example, for your thesis also, undergraduate, postgraduate, or even doctoral thesis. So long story short, it's very nice data. We look into this data and we assess the burden of multimorbidity in Indonesia. We observe that 1 in 4 per people in Indonesia aged 50 years old had multimorbidity. So 25% of older population aged 50 plus had multimorbidity. And what did we consider as the condition of multimorbidity? We can see the list of the diseases towards the bottom left of the slides. Among them, 6.5% had 3 or more non-communicable diseases of this nature. I would say that's quite a significant burden. And the prevalence of multimorbidity increased with socioeconomic status. So again, on the x-axis, here are the different age group. And on the y-axis, we have the prevalence of multimorbidity. In this graph, we have 5 different lines which show socioeconomic status. Q1 represent quintile 1 and Q5 represent quintile 5. So Q1 represents 20% of the poorest population and Q5 represent 20% of the richest population. So such a big discrepancy in terms of prevalence of multimorbidity. So we see that it was the richest population which has the highest prevalence of multimorbidity in all age groups, okay, in all age groups. And the poorest population, they reported or they have less prevalence of multimorbidity, okay, in all age groups. Okay, I hope this is understandable. But when we look at such data, we have to be extremely careful, because in IFLS, or in Indonesian Family Life Survey, all these conditions were self-reported, which means that the IFLS asked this question. For example, have you ever been diagnosed with hypertension by your doctor? Have you ever been diagnosed with diabetes by your doctor? And so on. So because it is based on self-reported diagnosis of doctors, this discrepancy between the poor and the rich should be treated very carefully, simply because possibly the poor people, they did not use the healthcare services as much as the rich people, right? If they did not go to the doctor, how would their doctor tell them that they had diabetes, hypertension, asthma, and so on? So this might actually reflect that they did not go to, or they did not use the health services as much as the rich people. Okay, so we have to understand this quite carefully, whether this reflects the true situation or it is because of the reporting bias. In epidemiology, we know there's a term reporting bias, and this is one example that could be a consequences of reporting bias between the rich and the poor. If everyone have the same access to healthcare system, if the poor and the rich, they got the same access to healthcare system, maybe this line at the bottom would be higher. Okay, I hope you agree with me. Maybe this would be higher if the poor also had access to the health system. But again, remember, the latest wave of IFLS that we analyzed was back in 2015. And in 2015, the Indonesian government has just launched BPJS. So by then, most of the populations, especially the poor population, they did not have access to insurance system. But since the government launched BPJS, the access to healthcare systems become wider, so more people could access the health system. And as a consequence, probably, if we repeat the IFLS now, we would observe a higher prevalence of multimorbidity among the poor. Okay, so this need to be aware of. So what's the problem with multimorbidity? In the next 3 slides or 4 slides, I'll show the consequences of multimorbidity. I'm sorry that it's quite busy, but let's just focus on these 3 parts. So here we measure multimorbidity and productivity loss. We measure productivity loss in terms of labor participation, if they could participate in the labor market or not, if they miss some days of primary activities because of sick leave, if they have to be confined in bed because of sick leave or because of multimorbidity. Let's say a person has stroke, diabetes with a complication that they could not go to work, they have to take sick leave and they have to rest in bed. Okay, so this number here, they are similar to the graph to the right. So if we look at focus at labor participation. Yeah. So the opportunity to take part in labor markets, if they have one non-communicable diseases, their odds ratio was 0.65, and I hope you understand how to read this number. The reference point is 1. If someone has 0.65, it means that someone is protected for the outcome. So which means that someone with non-communicable diseases could not participate in the labor markets. If they have one chronic diseases, their chance to participate in the labor market decreased by 35%. How do I get 35%? I take 1 minus 0.65. Okay, 1 minus 0.65, that is 0.35, multiplied by 100, that is 35% less chance to participate in labor markets. If they have 2 NCD, they have 55% less chance to participate in labor market. If they have 3 plus NCD, 3 or more, they have 77% less chance. So it's quite clear there's a very nice gradient here. Unfortunately, their chance to participate in labor market decrease as the number of NCD increase. Okay, I hope you follow what I'm saying here. So now if we look at day of primary activity missed, if they have to take sick leave, for example. So now the outcome is being in sick leave. Having one NCD increase their chance by 25%. So now we see all this number above 1, therefore I say increase their chance. Over here we say protected, okay? So 2 NCD increase their chance to miss the work by 90%. 3 NCD increase their chance to miss the work by 159%. So 2.59 minus 1, that is 1.59, multiplied by 159%. Having 3 NCD increase their chance to be confined in bed by 164%. So it's very clear, multimorbidity is a serious problem to productivity loss. It decreases the chance to take part in the labor market, increase the chance to be on sick leave, and increase the chance to be confined in bed. So now we look at health services. People with multimorbidity, 3 or more diseases, also has higher chance to visit outpatient care, polyclinic jalan, 366%. Okay, 4.66 minus 1 times 100%, 366% higher chance to visit outpatient care, and 325% to use more visits. Same picture we look at here in inpatient care. So on the top here is the outpatient care, and at the bottom here we have the inpatient care, rawat inap. So with multimorbidity, 269% higher chance to have any inpatient care. Okay. So finally, the last 2 slides, I think, on this topic is out-of-pocket expenditure. Again, I have to remind everyone that this data was from the survey in 2013 to 2015. By then, we did not have BPJS yet. So this data might look different if we do the study again now. Okay, so this is again from the IFLS study. It's quite messy over here. So what we see here is out-of-pocket expenditure. What we mean by out-of-pocket expenditure, if you get ill, if you go to the hospital, you have to pay the expenses out of your own pocket, out of our own pockets. Yeah, no insurance. So 15.7% of people in this study reported that they had to pay out their own pockets. But when we stratify these results by non-communicable diseases, 10.8% of those with no NCD had to pay out of their own pocket, and it increased significantly to 15.4% for those with 1 NCD, 22.6% for those with 2 NCD, up to 31% for those with 3 or more NCD. So the more non-communicable diseases people have,
we still have 3 minutes to go. Sorry.
Okay, thank you very much. I think I'm almost through these slides. The more non-communicable disease people have, the higher the expenditure out of pockets. And in terms of amount of money, we see that I think this is in 1,000 rupiah. I think I have to recall this again. But if we look at the number, it keeps increasing. If people with 3 or more NCD, they have 3 times as much as those with no NCD. So non-communicable diseases increase the expenditure, out-of-pocket expenditure. And we know the term catastrophic health expenditure. This is defined as if we have to expend more than 40% of our non-food expenditure for medical care. Jadi biaya yang dibutuhkan untuk kesehatan, pengeluarannya itu lebih dari 40% biaya rumah tangga. That is what we refer to as catastrophic. And here we see also as the number of non-communicable diseases increases, the chance to have catastrophic health expenditure increases also. Okay, I think this is second last slide. So we have talked about multimorbidity of non-communicable diseases. It increases health service users, increased productivity loss, and increased catastrophic health expenditure. And what is the consequences of multimorbidity of non-communicable diseases? This can lead to poverty and poor socioeconomic status. Orang menjadi miskin karena penyakit tidak menular, karena tidak bisa bekerja dan pengeluarannya lebih banyak dari pemasukan. But this is what we call as the vicious circle, lingkaran setan, karena orang dengan sosioekonomik yang rendah, people with poor socioeconomic status, they tend to adopt poor healthy behavior, poor lifestyle behavior. And as a consequence, they tend to have more chronic diseases. But now we have COVID-19 in the middle. We know that people with multimorbidity, they have higher chance to get COVID-19. And also people who are poor, they also have higher chance to get COVID-19. So this is what I referred earlier to as the syndemic of COVID-19, chronic diseases, and social determinant of health. We are not quite sure yet if COVID-19 will lead to poverty. But of course, if this pandemic continue, many people could not work and probably fall into the poverty trap. And COVID-19 could also lead to non-communicable diseases. We don't have a lot of knowledge on this yet, but some studies have shown that people with COVID-19, they have higher risk to get diabetes, for example. Okay, but then the last slide is we certainly have a problem now with COVID-19. But even before COVID-19, we have problem with non-communicable diseases. So this seminar talk about the legal and ethical aspect of health services during COVID-19. So I'll just show these slides for you to discuss later on. Here on the left, we see the burden of disease in the world. 67% of the world population die because of non-communicable diseases. 7% die because of tuberculosis, HIV, and malaria. So back in 2015, despite the fact that tuberculosis, HIV, and malaria kill 7% of the world population, they receive up to almost 40% of the global health fundings. A lot of research focus on these three diseases. But on the other hand, if we look at non-communicable diseases, which kill 67% of the world population, they receive less than 1% of the fundings. So my question, of course, is, was this or is this ethical? Right? Is this ethical to not finance non-communicable diseases? But maybe when we have COVID-19 now, the world will pay more attention to non-communicable diseases. Because now we know people with non-communicable diseases, those with multimorbidity, they're at higher risk to get COVID-19. So the question is, will more attention be paid to non-communicable diseases following the COVID-19 pandemic? I don't know, maybe. Time will tell, I think. I think that will be the last slides, and I thank everyone for listening and stay healthy. Thank you very much.
Applause to the professor. Okay, that was excellent, Professor Navi. So we are surprised with the fact raised from the presentation that to the pandemic of COVID-19, there was disruption in services for NCDs for both treatment as well as rehabilitation, including cancellation of elective care, the care that has been planned before. Okay, then the pandemic also bring up the burden of multimorbidity, where one out of 4 people aged more than 50 years have multimorbidity and leading in productivity loss, which considered as a serious problem for the country. Okay, thank you. And now we move to the discussion session. I would like to check the chat room. Okay, here we got question from Nilu. Okay, from Nilu. He's asking, good morning, Professor Navi. Thanks for the time. Let me introduce myself. My name is Nilu Desi Mahariani. I'm from Postgraduate of Midwifery. Please allow me to ask based on the real cases at work. Patients exposed to COVID-19 with comorbidities always accelerate the decline in patients' health so that it can cause death. What did it happen? Why did it happen? Sorry. Why did it happen? What is your opinion about this case? Thank you. Okay, the professor can address the question from Niluh Desi Mahariani. Thank you. Thank you.
Yes, terima kasih Bu Nilu. Though I'm a medical doctor, I'm not practicing medicine, so I'll try my best to answer the questions. As many data and many studies have shown, the comorbidities of non-communicable diseases increase the risk of COVID-19 infections, increase the risk of COVID-19 hospitalization and subsequently deaths. So the biological mechanisms behind this are still under study. I think we still don't know many pathophysiology of COVID-19, why it could lead to, for example, people with COVID-19, will they have higher risk to get diabetes? What is the mechanism behind that? I think these are still yet under study. But what we know is that COVID-19, of course, is an infectious disease. So many of the non-communicable diseases like cardiovascular diseases, they also have inflammation nature. So it could be because of the inflammation nature of COVID-19 increase the risk of people with some comorbidities to have more complications. So I'll stop there, I think. I would say the inflammation nature of COVID-19, that is probably one root cause of the problem.
Okay, that is the answer from Professor Nabi. Okay, I would like to check another question. There's no question. Yeah. We have another question from Nur Hadia. Good afternoon, sir. My name is Nur Hadia. I'm a new student from Postgraduate of Midwifery. Thank you for your explanation. In your opinion, what is the most effective way or any innovative way to continue to serve patients with NCDs while we are currently fighting COVID-19? As we know, some countries are implementing to minimize non-urgent care. Meanwhile, NCDs are also important to be treated because it causes many deaths. Thank you. Okay.
Thank you very much, Bu Nur Hadia. I would say maybe one of innovations that could be used to handle NCD patients during the pandemic case is digital health, or we know as e-health or mobile health. So many patients, many NCD patients, as we saw in the previous slides, they did not get their treatment because of the services were closed, particularly during the first wave or second wave of the pandemics. Couldn't we think of using e-health to take care of patients? As you say, many governments have closed their services and reduced deficits of non-urgent care, non-emergency care. But of course, hypertension treatment is not emergency. But still, the patient need to get treatment. Could we think of using, for example, e-health platform to inform patients about the disease, to inform patients about the needs of treatments, and actually to deliver treatment to patients? So development of mobile technology or digital health during pandemic has increased in many settings, and there have been quite a lot of study to use e-health or m-health or digital health, whatever we refer to it, to increase, for example, patient adherence. And in many places, people also use it for distance consultation between patient and doctors. I think in Indonesia, such application or websites or portals have also grown during the pandemics. So in short, I think digital health would be a way to go.
Okay, so the answer is the innovative way is the digital health, one of the solution maybe. Okay, thank you. And there's no question in chat room. I would like to give chance to you, the audience, to raise the question. Maybe you can unmute by yourself and you can go to ask the question to the professor directly, okay? Who will be unmute yourself and then ask the question directly to the professor. We still have 3 minutes to go. Okay. I give the chance to Dr. Mardiono to ask the question. Okay. Okay, Dr. Mardiono, how you?
My name is Mardiono. I'm focused on, right now, we starting for invest in the vaccinations. Means that the number of the COVID patient already decreased significantly. And then what you suggest for our health program approach to prepare for the people who have more high morbidity, still have a high risk in the COVID. Because when we considering the program and then the budgeting means that we like to achieve the human capital productivity in the future. Right now, mostly in Indonesia is a good young generations. What the best way to approach the program in the future? Because we have a nurse, a medical doctor, and then public health, and now the epidemiologists also focus on the investment on the future. Thank you very much, Prof. Navi.
Thank you very much, Dr. Mardiono, if I recall correctly. Yeah. Thanks. That's an excellent question. I think it's a very difficult question to answer, I believe, because of the nature of COVID-19 that we still don't know. There's still a lot of mystery on COVID-19 that we have to solve. We thanks the government effort. I think in Indonesia, the vaccination has outreached large number of populations. Of course, we still have way to go before we can vaccinate the majority of the populations to achieve herd immunity, as many people discussed already. I think the challenge of vaccination is to educate the populations that no one will be safe until everyone is safe, and that is the WHO slogan. So we have to achieve, hopefully, full coverage of vaccinations. The challenge, of course, is to address the vulnerable populations. And luckily, I get a new funding this year to do a study on vaccination in Sweden for three years. Even in a high-income country like Sweden, vaccinations resistance is still a problem. In many surveys conducted by the Public Health Agency, we noticed that 15% of the population did not want to be vaccinated. So the challenge is how to identify this 15% of the population and how to address them and how to educate them, improve their health literacy to get vaccinations. So we could achieve the herd immunity. So back to your question, I think one program that the government should do is to improve health literacy of the populations. So health literacy to the pandemic, health literacy to the importance of prevention programs. I mean, when we study public health, I remember I taught public health 20 years ago at Gajah Mada. The three basic pillars of preventions, promotive, preventive, secondary, and tertiary preventions. Those are the things that we should strengthen, especially promotive and preventive, primordial and primary preventions for COVID-19 or other pandemic. So health literacies, health promotions, primary prevention, I think those are important. I'm not sure if we could rely on, I'm sorry to say, I'm not sure if we could rely on COVID-19 vaccination. We know that it works, it protects us from the disease. But the big question, I don't think anyone knows, is for how long, right? In many settings, they try to give booster vaccination already. I think at least in Sweden here, older people who have got the second dose of vaccine longer than 6 months ago, they are suggested to get the third vaccinations. So because we still don't know how long the vaccine will work, and if we need to give a booster vaccination for everyone, this will take another few years, at least for Indonesia. So until we know that the vaccine is effective, I think promotive actions, preventive actions to prevent exposure, to prevent getting COVID-19, I think is most important. So I would say improving health literacy, improving promotive actions should be the priority of the government. And of course, when the pandemic happened, I think we need to do the 3T, testing, tracing, and treatment as effective as possible. Because if we could contain the cases, then we could control the pandemic more effectively. But of course, it's easier said than done. I'm fully aware of that because we have so many challenges in the field. But I'll stop there. Thank you very much for the question.
Okay, that was the excellent answer. Okay, and that was the end of our discussion with Professor Nawi. Professor Nawi, could you please hang on a minute? We want to show the certificate of appreciation from the committee to you. Okay, here it is. Congratulations and thank you for a valuable sharing with us. The certificates will be sent to you shortly by email. Thank you. On behalf of the committee, I would like to say thank you very much for spending your time with us, sharing valuable knowledge with us. Professor Nawi, it's our pleasure if you could continue joining us, but if you still have another business to be done, then it will be fine. Thank you so much.
Thank you very much for listening, and thank you very much for the invitations.
Okay. Now, let's continue with the next or the last speaker, but we have another platform here. We will have Associate Professor Dr. Yuttapon Vishanin. He's from Mahidol University, Thailand. And the presentation from the professor will be done via video recording. But before we proceed with the video, let me introduce him to you. Associate Professor Dr. Yuttapon Vishanin graduated from Mahidol University with the degree of Bachelor of Sciences in Radiological Technology. He received his Master of Sciences in Information Technology at Mahidol University. He was granted a Royal Thai Government Scholarship to continue his Master of Sciences in Information System from Hawaii Pacific University and a doctoral degree in Communication and Information Sciences from University of Hawaii, Manoa. Currently, he is an associate professor at the Department of Radiological Technology, Faculty of Medical Technology, Mahidol University in Bangkok, Thailand. He has focused his professional expertise upon the intersection of ICTs, radiation technology, and education. And the topic which will be delivered by the professor is about ethics and legal aspects of using health electronic data for research in industrial era 4.0. Okay, ladies and gentlemen, should you have any question or query regarding the topic, you can write an email to Professor Yuttapon. The email will be shown. The email will be written in the chat room, and the professor will address your question by email also. Okay, now we will proceed with the video.
Hello everyone, my name is Yuttapon Vishanin. Today, my talk is about the ethics and legal aspect of using health electronic data for research in the industrial era 4.0. I would like to present it in a little bit technical perspective. My short bio is here. I am currently an associate professor at the Department of Radiological Technology, Mahidol University in Thailand. If you would like to know me more, please visit yuttapon.com. I also serve as the Director of Education of the ISRG. You can visit the ISRG website or Facebook at isrg.org. This is my agenda for today's topics. At first, I would like to give some example of PDPA implementation in Thailand in an overview perspective. I will talk about basic principles in information security. I will give some demos, examples. I will show you attack maps, Google hacks for educational and demonstrational purpose only. I will talk about health information and related laws, international standard for information security management systems, possible cause of data risk, and I will show and tell some researches with anonymized data. Thailand PDPA. Thailand has implemented the Personal Data Protection Act in the 2019, or in short PDPA. It was published on 27 May 2019 in the Royal Thai government. Guess the PDPA is the very first consolidated law governing data protection in Thailand. If you want to see more detail, you can visit the website here. Basically, the laws indicate the Personal Data Protection Committee has to be set in order to establish for the PDPAs. For the committee or PDPC, they will have the power and duties to determine the measures or approaches for operation relating to the laws to promote and support the protection of personal data. This is very important because our data, personal data, will be protected by this law. And they also issue notifications, sometimes warning or orders, so to anyone to follow the PDPA, and also they can establish rules, guidelines for the personal data controllers. This is another entities that need to control the data, and also the personal data processor or the one who process the data to make sure that they follow and comply with the laws here. So in Thailand, we have three entities: PDPC, the committee, and the personal data controllers who have governing the rules, and the personal data processor or who is processing or working with the personal data in organizations, right? So the committee, the controllers, the processor, these three entities will work together to make sure that our data will be protected. Key definition, right? What does it mean, the data controller? It is a person or legal person who operates, you see, by collecting, use, or disclosures of personal data, right? So basically, they are the one who use or operate the data. Like in our organization, we will have like data collection form or something like that. So these are data controller in Thailand. So if we are a researcher, want to do research, maybe we are in these categories, the data.
Okay. Okay, that's the end of the presentation from Associate Professor Dr. Yutapon Pisciani. So, for the committee, can you please share the email so that the participant can write the question and send the email to the professor? Okay. Okay, that's the end of the presentation of the Professor Yutapon. So, oh, actually the video is not finished yet. So we will continue to play the video. Sorry for this inconvenience due to technological problem.
Semarang hebat. Semarang.
Okay, while we are fixing the problem,
Kota Semarang adalah salah satu kota metropolitan terbesar di Indonesia.
The postgraduate study program.
Harmonisasi sejarah dan akulturasi budaya yang selalu dijaga, diiringi dengan perkembangan perubahan wajah kota Semarang yang semakin indah, membuat masyarakatnya merasa semakin nyaman di kota yang merupakan ibu kota Provinsi Jawa Tengah. Politeknik Kesehatan Kementerian Kesehatan Semarang merupakan salah satu politeknik kesehatan yang berada di Provinsi Jawa Tengah yang berdiri sejak tahun 2001. Program Pasca Sarjana Politeknik Kesehatan Kementerian Kesehatan Semarang. Diawali pada tahun 2015, Politeknik Kesehatan Kementerian Kesehatan Semarang dipercaya sebagai satu-satunya politeknik kesehatan di Indonesia yang memiliki program pasca sarjana Magister Terapan Kesehatan.
Visit.
Okay, we will continue playing the video.
The data controllers, like the data processor is a person or legal person having the power and duties to make decision, to collect, use, or disclosure of personal data. This one is like a policy maker in the organizations, right? So personal data, what it is any information relating to a natural person, right? Not a dead person, just a person who living, with enable identifications, right? Not including the diseased person. So the dead people is not included. So basically, it is any information that can link to the person or identify the person. So basically, a lot of things like national IDs, names, last name, email, whatever that related to us and then can point back to us. So what is the sensitive data? So it means any personal data, right? Including so many things like like the knowledge or information about that people or that person, right? Including, you see, genetic data, biometric data, any data that may affect the data subject in same manner of the prescribed by PDPC. So it means that if PDPC said this kind of data is a sensitive data, it is, right? So basically, it is any data that point out so many aspects of a person, right? Genetic data, right? Biometric data, and I'm sure including imaging data of us, right? So if we are radiographer or and health science that doing the research, so you consider a subject data is a sensitive data. So what is the principles of the PDPA? Basically, PDPA require us to maybe minimize the use of the personal data, make it a little bit difficult to use. I mean, because we need somehow to limit data collection to make it private, right? So the collection of the personal data must be limited to somehow only the necessary information can be collected, right? The data processing notifications. So the subject must be informed before you collect the data from them, right? Prior to or at the time of collection of the personal data. It means that if you want to recruit someone into your research, they need to be informed, right? In a required detail. So not just say that you will be included in the research. You need to tell them like the purpose of the data collection for research and how long the data will be kept. How long? You cannot keep it forever. Like you need to delete it someday, and how to delete it, when to delete it, right? And also the right of the data subject is mean that you not own the data, right? The data belong to the subject, right? You just keep it, right? Except in the case where the data subject already knows of such detail. If they know already, someone tell you along the process of the research, the steps, right? Maybe your friend tell the subject, so you don't need to tell it again, right? So if they know, the subject already knows, so you don't need to tell them. But if not, you need to tell them at the point that you collect the data. This is very important. Like if you write a research proposal, the IRB or the research ethics committee will scrutinize your proposal to see if you follow the guideline here. So we have Thai PDPA example, like legal basis for collecting, processing personal data from this YouTube video. So I will play YouTube video for you. So the main principle of the Thai PDPA, right? So you need to tell them objective and collect only necessary data. You not collect everything. You need to collect like very limited set of data that you need to use it. Otherwise, it violates the PDPA, right? So the data collection need to be consent or need to be provided or explained before you do the data collection, right? So it is an ethical way to do it. Do no harm, right? And this one is also a very important aspect, right? Risk and benefit, security, right? Maybe you need to keep it confidential for your research only and not disclose the data to someone else. So this relates to the principle of information security here. So how, I mean, it is security related issue because the data is a sensitive data, right? So you need somehow to manage according to the policies by the controller, right? And by the regulation or the laws here to make it possible for the data privacy, right? So you have a lot of rules and laws internationally and locally, right? For Thailand, we have Thai PDPA, right? And I searched the web and I saw like a webinar on the Indonesia webinar on data protection and privacy in the August, right? In EU, very strict. In the US, long time ago, they implemented here. HIPAA, for example, this one, regulating the healthcare providers data collection from the patient information or health information from a person, right? So basically, information security, what it is, it relating to the confidentiality of the data. It mean keep secret or not, right? Integrity of the data is mean who get to the data, who modify it, right? You can check integrity is correct or not, is modified or not, right? It is the authentic data or the fake data, right? The next one, availability is mean that the data available when you need it, and with the maybe with the right to access or right to update or right to delete, depends on your role, user role or user right to do what, right? It's like you log in to the system and you can have read only permission or just read write permission, or you can have read write and delete permission. So we need to control that. So basically the principle is confidentiality, who can access it, who cannot access it. Integrity, is it authentic, right? Availability, you can access it and it is available for you, right? Very important concept here. So cybersecurity statistic fact for 2021, right? A lot of cybersecurity breaches caused by human error, 85%, a lot, right? The next one, very, very important here, very scary here, malware delivered by email. So 94% is a lot. So if you got email from the one you don't know, please don't open it because you will be infected by a virus. So ransomware attacks, every 10 seconds, 71% of the cyber attacks are financially motivated, right? So very scary here. So the damage costs a lot, 6 trillion a year, even to 190,000 a second. Oh, that's a lot. So be careful. You have sensitive data, so maybe the hacker want to have it, or you just unintentional expose the data to someone else, maybe copy and they forget to delete it. Something like this may happen. So we have hackers, and just want to inform or tell you different type of hackers here. Basically, we need to be careful because we have sensitive data, maybe in the hospital, maybe in your research, right? So we have black hat. This is the bad guy, right? Who want to hack it, right? Gain money from hacking, right? White hat, this one ethical hackers who protect the system from bad hat, right? Gray hat, maybe depends on their mood, right? Maybe curious, right? Maybe they want to test the system without permission, right? But typically don't cause any harm, just want to gain into your system to have knowledge, and that's it. Red hat hackers who use cyber attack to attack black hat hacker. So this one is again the black one, right? Blue hat seek to take personal revenge. Maybe they are fired from the organization and they want to revenge by hacking to the organizations, right, or the company. Green hat, this is maybe sometimes we call it script kiddie, mean that the one who's just start trying hacking, learn to hack, right? So sometimes you will be this, right? Just want to test the system, and then sometimes in unintentional hack to whatever you have in the system, right? So basically, The white hat is a good guy. The gray hat is sometimes good, sometimes bad. And then the black hat is the bad guy. Right? So basically, in the organization, including a hospital, need to have the security team. And then they have different roles. Like white team, it means like the green team do what, like prepare, and then yellow team is the coder, right? The designer, right? Orange team, like just for education. The red team, like offensive, is trying to break your own organization in order to prevent it from hacker outside, right? So we have different kind of team to prevent the data in organization. Why I have to tell you this? Because this year in Thailand, so many hospitals, including some part of the Minister of Public Health, has been attacked by ransomware, right? And a virus infected, and then they encrypt or lock the data, and then you cannot even access your data, cannot get it back unless you have backup. Otherwise, you need to pay the money, right? So it's very scary, right? So I already talked about this a lot. So next, let's try to see the real world, the current times that we are talking here. A lot of attack happens. So I will show you the videos. You can see from the screen here, we have digital attack map. It records activity over the internet over the period of time here. So you can slide down here from 2016, what happened, and then you can fast forward here. A large volume of attacking here in December to 2018. Yeah, maybe something happened during this period. China, and then so many countries participating in the hack, Europe, India. See what happened, and you can change the time frame here, right? Maybe latest is the May 17, 2021 here. A lot. Next presentation is the simple Google hacks, just for demonstration and educational purpose only, because this is very dangerous. They are out there. They have the website called exploitdb.com. You just search Google hack and then it pop up, right? Google hacking database. What it is? Actually, it is the way you use example to hack using Google, right? So we try to act as a white hat team, hacking ourselves to make sure that any risk can be protected by informing the IT when we found the part that dangerous in our organization. For example, we do self-testing. I just use this one, right? I found in the database, right? I use this line in URL, and then this one I pre-record. So it means that I have tried and then it works, right? I try to find Excel files that contain password from some government website of Indonesia. And I found like they have password, a lot of password. And then we just demonstrate, right? Don't do it. So I can download an Excel file, contain username, password, and then the institutional branch. I don't know what it is because the Indonesian bahasa, so I don't understand it, but I got a lot username and password here, right? So if you don't have any knowledge of hacking, you still can hack it, right? From this, you can see Mark Zuckerberg, right? Instagram, his office, right? And look at his computer. We zoom in and you see that the mic and the webcam is blocked using the black tape here, the microphone and the webcam, because the software can silently record your video from the webcam and silently record your voice from the microphone. Health information and related laws, information security or information privacy. So we have in the US video one, your healthcare information, your right. This a short video that the government make it and then tell you that you need to keep your own privacy right. Video number two, your health information, your right. So I will play this video for you in the next section. Basically, the video explain our privacy right for the US HIPAA laws, right? So we need to know that the health information is private and should be protected, right, by the law. Also, we have HIPAA in 1996, the Acts, the Health Insurance Portability and Accountability Acts, right? This one used a lot, heavily used in healthcare in the US, right? So what it is, they try to educate the people that you can get your personal data from the providers. You can ask it, and can I have my medical record, right? And you need to check it to make sure it's correct, right? Because the data, the personal data is belong to us, right? So we also can request the list of people who access our data, right? Know who has seen it, right? You have control, right? So our data is used among the medical staff here, like physician, pharmacy, medical staff, and across the organization, across the information system, right? Electronic medical records, mobile apps, labs, hospital, web-based portal. So this belongs to us. So it is our right to control our information. Right? In this slide or this section, I would like to talk about international standard for information security management system, or we usually call it the ISO 27001 here, right? This is the number for security system, right? It is a set of standards. For the first one, it talks about the security technique and the management system overview and vocabulary. You can buy it, like 166 Swiss francs here. Talks about the vocabulary here, and you can buy the next one, the technique and requirement of the system at this price. So it tells you about the requirements for establishing, implementing, and maintaining and improving the security management system in your organizations. It's like if your hospital would like to improve the security management, or even you get a concept for your research, this is probably the one we should look at it, right? Requirements. And we have a code of practice, what we should do, what we shouldn't do, something like the do or don'ts, right? You can buy it. But basically what it is a document that talks about the how to manage their security in the organizations. So basically it's a set of the processes together to help out the organization to manage their information security. To do what? By assessing the risks here and take actions to reduce them. So it means you have risks, then you have gap, right? It's like gap analysis, and then you try to minimize the gap here. So you reduce the risks, right? So it's simply a set of things that you must do to keep on top of your information security. So the main components of the ISO 27001, right? Basically, it is a policy set, like what is your subject data? Is it secure? What should we do? And then the objectives, right? Trying to do with your data, how, right? First, so you need the risk assessment, right? So it tells you where is the risk, and then how to minimize them. And then it also talk about the roles and responsibility of the person or the employees in the organization, what to do. So with your research, so it means like, what are your rules on keeping your data subject secure? How to do with your data and subject data leak, and how you stop it, right? It's like we think about the risk and who does what in your research. So compare, the standard here and the research, your research. So it's kind of like I try to draw the line here. This is a standard. This is what you can do with your research, right? Competence. So does everyone have the skill that they need to work with the data in your research, right? Awareness. That everyone in your team aware of the information security, right? Do you have any monitoring or measuring, like quantifying what is going on, accessing and using your subject data? Do you have tracking system who can read, who can write, who can delete, who can modify? Can you track it, right? Internal audit. So it's like independent checks of what is going on with your data. You have to have the system, right? Management review. So if you are the one who taking care of the management of your research project, so you need to review everything, right? To keep it under your control here. So basically, this is international standards, and this is your research. This is the concept of the ISO 27001. So it's not just one shot, right? It's not just one shot measures. It's like ongoing, continuing measure, like you plan and you do, you check, and then you act and you check again. So with the triangle of the information security, right? Confidential, integrity, availability. So this is your data in your research. So you keep doing this kind of the activities to keep everything secure, right? So if you are curious about the standards itself, I take this from Wikipedia, and then the standard is like huge. So we have like hundreds of control in several groups, right? And 35 categories. You have the policy here, you have human resource, you have this one interesting, cryptography, right? Operation, right? Communication, supply relationship, or everything throughout your organization, every part need to be secure, right? So what it is about the cryptography, I would like to give you an example. We have in security, we have what we call hash. What does it mean? The hash function is like function of X, like this, right? Y. If you give X and you got Y here, right? So hash function, what it is, it convert from, it's like encryption or cryptography that you can use to map data to site of fixed length value here. The value returned back from the hash function we call hash values or codes or digest or simply call hashes here. Let's see the example so you can get more understanding of the hash. It's like we have the word fox, right? And we have hash function here. If this one X, right, you get Y here. And then the hash function will give you like consistency length of the Y. So for example, like hash function A give like 1, 2, 3, 4, 40 bits, 40 character long here, right? So whatever, how long, doesn't matter if X is like 3 characters long or just like a paragraph or just a sentence, it will give you fixed length here of Y. For example, you give X like fox here and you get this value, you see, start from the FCD and ending with 2D17 here. And next you give X as a sentence, like the red fox jumps over the blue dogs here. The same hash function will give you the same length output of the digest here. So you see that character here is totally different with this. Even you change only one character here, like over from V here to U here, as function, you get totally different digest. You can see different, right? And this one, you change one more character or just switch the character here as an X with the hash functions, totally different output, you see, and not repeat. I mean, if, you know, like even you change just one character is totally different here. Or you cut one character here, gone. The hash function also provide totally different 40 character in length here, right? This is a hash. So basically, this kind of hash function we use to keep password, something that we don't want anyone to know, right? For example, we have different kind of cryptographic hash algorithm, right? The thing is that when you get X and then you get Y, right? We don't have the way to convert Y back to X. No way. It's one way. It's only one way from X to Y. No way to get back X. If you got Y and then you want to convert back to X, no. It's just one way functions. So this is the name of the hash algorithms we have. Basically, this one obsolete, no use. MD5 you give you like 16 characters in length, right? SHA-1, maybe you get 20 characters. SHA-2, it varies. Sometimes you get 28. Sometimes depends on how many length. Here we get 48. We get 64 characters. Sometimes we get the even improvement of the SHA-2 here. So you get the corresponding length here. Maybe start from 28 bytes to 64 bytes, same thing, right? Currently, normally we use this SHA-2, right? We recommend not to use MD5 SHA-1 anymore. We start from here. What we can do? Let's see here. This is the back end of a web database. You have username here and password, right? Don't keep the plain passwords. Normally we do the hash and then we keep the hash value. So even the X, you just know the hash, that's it. So you don't know the actual password. What we can use here, for example, you sign up for our website to collect the data, right? Basically, the front end on the web, this one, the back end, web server here. When you get the password will be converted using hash and keep these hash values into the system. So the administrator doesn't know the password. They just know the hash, right? And the user log in, they retrieve the hash. For example, this one, MD5, but not recommend anymore, right? And when you type in the password, it will be star, right? And the software will convert to MD5 and we try to match if this digest equal to this digest, because it's one-to-one mapping from X to Y. It's 1 to 1, right? And no way to convert back. So basically, if it is matched, then the password that user input here and the password that saved as a hash in the system is match. So you confirm that it matched. And how? If you forget the password, usually you have the link to set the new password. You cannot recover the old password because the system and the admin doesn't know your password. They just know only the hash here. You can use this kind of the hash to keep sensitive data of the patient, and you can map like this, and what it is in the files and what it is in the hidden files that you keep the subject. The hash. Basically, we can do what with HN, something like this, or ID, something like this. So I will give you example how to keep your subject data in your research to be secure. Basically, what we can do, first, it is physical security. It means you lock the door, you lock the box, right? Physical. And with the technique, separation technique, what does it mean? We have two files, A and B. Here, Excels maybe. Unidentifiable data, shareable, you keep in the B. And identifiable subject data, you keep in the A here. Let's see the example. In my research, I have sensitive data here. I locked, right? It has first name, last name, HN, right? And I define the code for each subject, like subject ID here. And then I separate the subject data into different files that I can share because cannot link back to the patients. The one who share just know the subject ID, right? So this one can be shared, but this one I locked. Encrypt, file encryptions, and put in a USB and lock in a lockbox because this one sensitive data here. So I separate into two files. The one file that has to be locked is sensitive data. The one that can be shared with the team will be this one. All right. So please do this kind of technique in your research to keep the sensitive data apart from the shareable data. Right. So I would recommend you the 7-zip software is like WinZip that you can compress the files. It is a free software that you can download. It's open source, no cost. At no cost, you can download. It's like if you use the Windows 64-bit, you download this one. If you use Windows 32-bit, you download this one. I'm not sure if we have the Mac. I think we have the Mac version of 7-zip. This one, right? What you can do, basically, for example, I have subject data here. When you install it in your system, you will have the context menu here. When you right click, it pop up menu here, and then you select 7-zip, and we choose add to archive, right? And then it will create the files. You can use 7-zip format or you can use zip format, doesn't matter. But the thing is that it has this section that you can encrypt the files. You put the password, maybe whatever password you want, right? And then this one important, you need to use the AES algorithm that is more secure for current day. So you select the algorithm here, AES 256, and then You click OK, and then it will create zip files that the content is locked. Even anyone get the files cannot open, or the one that obtain the file, maybe hackers get the files and then they cannot open it because it's locked. Inside, when the data is locked, you got the asterisk or star here, right? At the end, you get the star at the end of the file names here, right? And then when you want to extract it, you need to put in password. Otherwise, you cannot open the files, and then it will be kept secret, right? So if the password doesn't match, you cannot extract the files here. So this is secure data, data security here. So that is the way. What is the AES? AES is an algorithm that you have secret key and encrypt, right? And then you give the key to the receiver, and then they can open it. Decrypt, encrypt, and decrypt, same key, right? This one. So you can unlock the file, right? Plain text in the file here. When you put the AES encryption here, it's unreadable. And then you put in the correct password, it can come back. It's kind of different from the hash. Hash is one way, but AES is forward and backward, right? With the key here. Or the hardware, right? That you save the sensitive data. Recommendation is the hardware should have AES encryption automatically inside, right? For example, like this kind of hard drive, SD, they have AES encryption, right? So if even the laptop is stolen, the data is safe, right? For example, WhatsApp message, right? They encrypt the message inside. Right? Google Cloud also encrypt AES encryption, right? And the next, when you complete the research, how to securely delete the sensitive data, how? There's delete button in your keyboard, on your keyboard doesn't mean that the data is deleted safely, right? So basically in the file system, what happens? You have file allocation tables and actual file on the disk, right? Basically it tells that file A, right? Take the space from A and length 2, right? So this one, 2 length, and then file B, right? Start from T3 and length 4 here. Right? When we delete it, what does it mean? It just marked on the table, like a table of content, that, oh, this section is deleted, but the actual content of the file is still on the hard drive. And if you have special software or you have special tools, it can be undeleted, right? It's not safe. Undeleting is possible, right? It's like take it off from the recycle bin here. So you have so many recover deleted file software here. Some are free, some are paid, right? So for the data erasers, right? We have 3 stages. It means clearing. So you remove sensitive data from storage device in such a way that it is assurance that the data may not be reconstruct or take it back, right? Purging is like physical rewrite. So you overwrite the data with something else, right? So data cannot be recovered and then destroy the hardware. So this is the standard, right? Like so many standards that you can do it, like what to do with the data, right? So data erasures, right? So you delete it, not only just mask here, delete, you write something else over the old data. You write 0 over the old data. So even it is undeleted, you get 0, but not the data you saved before, right? So I recommend you use File Shredder. It's free software from Microsoft, right? Desktop application for shredding, destroying unwanted file beyond recovery. So even you undelete it, you cannot read it because it's just zeros, all zeros byte. And you have some free and paid software for data eraser, right? But I just recommend File Shredder for Windows here. Bleach here, you can download it, clean your system and free this page. Direct boot and nuke here, you put CD-ROM and you boot it, and then it will destroy all data in your hard drive. So be careful to use this. This one is just maybe you want to sell your laptop or your organization want to dispose the hardware. So this kind of software is used on each of the machine before it destroy, right? And then this is a hard drive put in the shredder, and then it becomes small pieces of the metals. Or in DICOM, for DICOM, we have what we call DICOM anonymizing software. It will override to keep DICOM anonymized. It overrides the DICOM text or DICOM information in the DICOM header with specific value, maybe empty. Sometimes it write empty value, or sometimes it write random. Hence, right? Basically, this patient anonymization, you have to go through everything text here. A lot, you see. So many information, so much information inside the DICOM files that has to be deleted or removed before you can share the DICOM file. So be careful when you want to share the DICOM file. Make sure that you do the anonymizations using the software. So I can recommend DICOM anonymizer that you can freely available over the internet, and you can freely download it from the internet, right? It can anonymize one single file or anonymize the whole folders, right? So the next one is RSNA, clinical trial processor. So it has the function DICOM de-identification to local storage. It means that you take the DICOM and then you anonymize it and save on your local computer, right? Basically, if it is an image, some software just put the black color over the image here, right? Blackening features, right? Not only the header, but image too, right? So blackening it, maybe here, blackening it, right? Possible cause of data risk. So basically, cybersecurity incidents happen from what, right? Human errors, a lot. Be careful. From where? Viruses, worms, spyware, Trojan, ransomware, right? Virus, what it is? It is the software that try to infect your computer and then destroy your files. About worms, worm is kind of software that doesn't mean to destroy the file, but it tries to spread out or make an outbreak of the worms as soon as possible. So it need to infect to your network, and then it take over your network, right? So it will infect entire network quickly, right? Spyware, sometimes you go to the website and then the website silently install some suspicious software in your computer and then maybe taking your credit card or personal data, right? Spyware. We have so many different things: adware, keylogger, sound recording, browser hijack, something like this. So maybe this one keep recording what you type, and then this one keep recording whatever you talk through your microphone, right? Like this. Can you remember disable it or put the black tape over microphone and cameras. Right? Trojan is the software that look like it's okay. Legitimate software is seem that it's legitimate, but it is not. It silently infect your system and then take your personal data. And this one is popular right now here. It try to get into your PC and lock your files, and then you need to pay it back through Bitcoin, and then they will raise the price and then ask you for money again and again. So basically, we are recommend not to pay them, but you should restore from your backup. So this is why backup is important, because if you pay, it will ask for more. It will ask for more, and then because it's got your money, right? The hacker get your money, and then he knows that you are willing to pay, so he raised the price and then ask you for money again and again. So don't pay, just restore from backup. That's it, right? So what to do? I want to open the file from unknown contacts from email. SMS link, avoid it. No, right? Install antivirus, right? Backup, encrypt sensitive data, keep it in safe place, anonymize sensitive data, work offline if possible, avoid sharing password. So example of research based on anonymous data here. So what I did, I download from the database, ADNI, right? To make to use as my data in my research. So basically, the data inside the database is anonymized, so I don't know the identity of the subject, right? But I can still have the image to train my AI model, right? Basically, we can use the open database here, like ADNI data for doing machine learning or something. So anonymized data can be used in the research for sure, right? So you get the data to do your work, but not identity sensitive data. Removed, but you can still work with your data. Right? I would like to end my talk here, and thank you for your attention.
Okay, give a big applause for the video presentation from Associate Professor Dr. Yutapon Picianin. That was a very detailed and interesting video presentation from Professor Dr. Yutapon Picianin. It gave us better understanding about using electronic data for research with more awareness and precaution on using sensitive data and put into consideration for cybersecurity. We also thought about how to keep our sensitive data as well as how to delete or erase the data safely. And if you have any query or question regarding to the topic, you can write an email that has been shared in chat room. And we would like to show the certificate has been shown. Okay, and this will be sent directly to the email of the Professor Yutapon Picianin. Okay, praise be to Allah, the Almighty God, for finally we have reached the end of the last session for today. I would like to convey my big apologies to you all for every mistakes that I've made as the moderator. Wishing you enjoy that we've been through and have a nice day. Be healthy and be happy. Bye. I turn the floor back to the MC. Thank you so much. Assalamualaikum warahmatullahi wabarakatuh. Peace be unto you all. Thank you. Thank you very much, Mrs. Sri Widatinengse, Master of Midwifery, for an amazing session. Ladies and gentlemen,
Those are the agendas we had from the amazing speakers and moderators for the first day of the second International Health Conference with the topic Legal and Ethical Aspects of Health Services During Pandemic. For the next agenda, we would have it tomorrow at 8 a.m. sharp to begin, with some amazing speakers and other new knowledge. Tomorrow, we will have two main sessions. The first is invited speaker session, and the second is oral presenter session. We believe that our agendas for tomorrow can be more amazing, so please don't be late. This is all for today. Please have a good rest, and thank you very much for your attention. See you all tomorrow at 8 a.m. in the same link with a new bright smile. Let me finish with say Hamdalah. Alhamdulillahirabbil alamin. That's all. Assalamualaikum warahmatullahi wabarakatuh.
The COVID-19 virus spreads mainly between people in close contact with each other. It spreads most easily in crowded settings, closed spaces with poor ventilation, or through prolonged contact with an infected person. This is because, as a person infected with the COVID-19 virus breathes, talks, coughs, or sneezes, liquid particles of various sizes are expelled into the air. Larger particles are called droplets. Smaller particles are called aerosols. You can contract the virus if infected particles come into contact with your eyes, nose, or mouth. Whether you are inside or outside, always maintain a physical distance of at least 1 meter from others. When you are in an enclosed or poorly ventilated space, the virus can spread more easily. In these conditions, aerosols can remain suspended in the air or travel farther than 1 meter. When you are inside, make sure to stay at least 1 meter from others. Wear a mask. Open a window to improve ventilation. And limit your time spent in these settings. To protect yourself and others, always follow these 6 precautions.
The novel coronavirus disease, COVID-19, is caused by severe acute respiratory syndrome coronavirus 2, SARS-CoV-2. Since the first report of the virus in December 2019, there has been a rapid rise in the number of confirmed cases that contribute to mortality and morbidity. The disease's rapid spread and novel nature have created significant health concerns, particularly for pregnant women. In all populations, COVID-19 can cause respiratory symptoms, such as a cough, shortness of breath, and difficulty breathing. However, affected pregnant women have additional concerns about pregnancy and their babies. There have also been concerns about mother-to-child transmission via the placenta, mother's body fluids, during delivery, and while breastfeeding. Research is needed to determine COVID-19's true impact on pregnant women and their babies. To help identify these impacts, including COVID-19's prevalence, symptoms, and complications in pregnant women, University of Birmingham professor Shakila Thangarantanam and her team at the WHO Collaborating Centre for Global Women's Health are conducting a living systematic review. Here, the team is sorting through COVID-19 research to find the most robust and up-to-date information that can be used to inform and improve care for pregnant women and their babies. As of June 2020, the prevalence of COVID-19 in pregnant women admitted to hospital for any reason appears to be similar to the general population, with 1 in 10 pregnant women diagnosed with the disease. Of these, 39% reported a cough, 40% reported fever, 19% reported breathlessness, and 10% experienced muscle aches. However, the risk of having symptoms is lower in pregnant women than non-pregnant women. They are 57% less likely to have a fever and 52% less likely to have myalgia. While COVID-19 infected mothers-to-be were at a higher risk of intensive care unit than non-pregnant women, they had a slightly higher rate of preterm birth than non-infected mothers, and stillbirths and neonatal deaths were extremely rare. Risk factors associated with severe COVID-19 in pregnancy include increasing age, obesity, and pre-existing medical conditions. Fortunately, the risk of babies getting COVID-19 following childbirth and breastfeeding is low, so vaginal delivery and breastfeeding should be encouraged. However, founding studies have been relatively small, with high uncertainties. As a result, Professor Thangarantanam and her team plan to continue reviewing studies and compiling information to help support pregnant women and their babies' health, safety, and care. The current challenges brought about by COVID-19 for people all around the globe are unparalleled and have caused fear, anxiety, and uncertainty for so many of us. We are all going through this together, and it's important to understand that you're not alone in how you're feeling right now, and that there are practical, healthy ways to cope with these emotions. The COVID-19 pandemic has created unprecedented change and a need for a response from everyone around the globe. Many of us are worried about our loved ones and our livelihoods, and there is no one right way to cope with what we're experiencing. Remember, however you're feeling, there are others that feel the same. You are not alone. Here are a few voices of people struggling to cope during this time.
Some days I'm okay. I'm doing my best to adjust. But yesterday, I couldn't stop crying. This all just seems so unfair, and I feel so angry that this is happening to us. I'm struggling to care for my kids and work from home at the same time, and I'm worried about my parents' health. I watch the news and it just seems so hopeless. I don't know how to keep it together.
I feel so lost and sad. So much has changed. I used to have dinner every week with my family, but now I can't be in the same room with them. I really miss them.
I'm missing out on my prom and my graduation. I've literally been looking forward to these things my whole life, and I'm heartbroken.
With everything going on now, I just can't stop my thoughts. And physically, my chest hurts, and I can't breathe. I get nauseous thinking about what could happen to my family and my friends.
Before this happened, I used to worry all the time about getting sick. Now that worry has turned into absolute terror. My heart races every time I have to go to the store. What if I bring germs home with me? I can't stop washing my hands.
No matter how exhausted I am, my sleep is still terrible. I just keep picturing all the things that could possibly happen. Will I ever get a good night's sleep again?
I've been through so much already. I don't know how I'm going to deal with this too. My flashbacks are getting worse and worse.
Honestly, I feel like I'm more comfortable in times of crisis. I'm not sure why I don't feel as upset as everyone else does right now.
I don't know when or if everything is going to get back to normal. I feel like the weight of the world is on my shoulders. How many people are going to be affected? What does this mean for me and my family?
We've just heard some of the ways people are being affected by the COVID-19 situation. Here are some things that are helpful in building resilience during times of crisis and intense stress. There are a lot of things outside of our control right now, which can be scary. By focusing on the things we can control, we can refuel ourselves and become more grounded and able to focus and cope with all of the things we can't control. One of the most important actions within your control is to follow CDC guidelines to reduce your chance of being exposed or passing the virus on to others. Use social support. No one should go through this alone.
There is absolutely no shame in talking about what you're going through with your friends and family, and it's important to be there for others too. Video chat and phone calls are a great way to stay connected. Prioritize self-care. Staying on a regular schedule, exercising, eating a healthy diet, keeping a sleep routine, and taking time to meditate or pray are all important, now more than ever. Be gentle with yourself. During times like this, you will have good days and bad days. Your emotions are most likely heightened at this time. Try not to compare your life to what you see on your friends' social media feeds. There is always more going on behind screens. Helping others can bring joy and gratification. Do what you can to help others, even if it's something as simple as lending an ear or making someone smile. Be kind to the people around you, especially the folks who are still out working, to ensure we all have what we need. If each day feels like an uphill battle, it may help to seek out professional support. To continue helping during this time of social distancing, many mental health providers are using telemental health in their practice. If you can't afford therapy or need to talk to someone right away, you can call the Suicide Prevention Lifeline 24 hours a day at 1-800-273-8255. You are not alone in how you are feeling. There are things you can do and resources you can use to cope during this challenging time. Check out our library for more videos to learn more about mental health, dealing with isolation, and ways to cope. We're all in this together.
Coronavirus, shoot. Let's fight the virus, protect ourselves. Coronavirus, shoot. And these are what we should do. Take our temperatures every day. Wash our hands frequently with soap. Cover our mouths when we cough or sneeze. We gotta stop the virus from spreading. Coronavirus, shoot. Let's fight the virus, protect ourselves. Coronavirus, shoot. And these are what we should do. Avoid touching our faces. Avoid sharing food. Avoid going crowded places. Wear masks if we're unwell. Coronavirus, shoot. Let's fight the virus, protect ourselves. Coronavirus, shoot. And these are what we should do. Drink lots of water every day. Have enough sleep and rest. Eat lots of fruits and vegetables, and let's exercise regularly. Coronavirus, shoot. We can fight the coronavirus.
During the COVID-19 pandemic, it's important that oral healthcare staff responsible for providing treatment take careful steps to protect themselves and their patients from infection. Treatment rooms should be very neat with limited storage areas. Hand washing is a key measure to prevent the transmission of infection. Staff should perform hand hygiene using an alcohol-based hand rub product or soap and water before putting on or taking off PPE and before and after treatment. Hand washing with water and soap should last for 40 to 60 seconds. Following these steps, wet hands with water. Apply enough soap to cover the entire surface of both hands. Rub the palms of the hands together. Rub the palm of each hand against the back of the other hand, interlacing fingers. Rub hands, palm to palm, interlacing fingers again. Rub the back of fingers on opposing palms with fingers interlocked. Rub the left thumb in the right palm and vice versa. Rub clasped fingers in a circular motion on each palm. Rinse hands with water. Dry hands thoroughly with a single-use towel and then use the towel to turn off the tap. Oral healthcare personnel must be trained to use appropriate personal protective equipment, or PPE, ensuring they understand how to put on, use, and remove PPE to prevent self-contamination. When putting on PPE, they should perform hand hygiene, put on the gown, then the mask, then eye protection, and finally gloves.
Next patient, please. Hi.
I see you have bad tooth decay. We will give you an anesthetic and proceed with a filling.
Instrument packaging is important as it allows the instruments to remain sterile until they are used, reducing the risk of cross-contamination. During the pandemic, the World Health Organization recommends avoiding or minimizing aerosol-generating procedures, or AGPs. Instead, dentists should use less invasive restorative techniques using hand instruments. If an aerosol-generating procedure is required, a fit-tested respiratory protection is recommended.
I have finished. Your tooth is filled and should no longer cause you pain. If you can just spit into this cup, please. Are you feeling okay?
Yes.
My assistant will take you back to the waiting room.
At the end of the treatment, the assistant should send the instruments to the sterilization area. Respirators, surgical masks, gowns, and gloves should be discarded after every patient. Reusable eye protection and face shields must be cleaned and disinfected prior to reuse. There are temporary strategies for reprocessing masks or respirators. Reprocessing should be only considered when there is a critical shortage of PPE. Personnel should perform hand hygiene twice after glove or gown removal and after removing eye protection or masks. To further prevent the possibility of any aerosol transmission, there should be adequate ventilation in all patient care areas. It's best to choose natural ventilation and avoid the use of air conditioners or other types of recirculation devices. Air filtration systems can also be installed, with professionals carrying out any air conditioning maintenance. By following all these steps when treating patients, we can help to reduce the transmission of COVID-19.
The Global Action Plan for Healthy Lives and Wellbeing for All, SDG 3 GAP, aims to improve the collaboration of 13 agencies across the multilateral system to support an equitable and resilient recovery from the pandemic and drive progress towards the health-related SDGs.
Our aim remains stronger collaboration for better health.
The SDG 3 GAP was born at a time as we gained a deeper understanding of our need for it before COVID-19 hit.
We were already lagging, with at least half the world's population still unable to access essential health services. We thought, surely we can do better.
It's 2021, and we are not only further off track in achieving the SDGs, but for the first time since their adoption in 2015, progress on the goals has been reversed.
We are supporting countries in a world where inequalities are growing and inequities persist.
COVID-19 has exacerbated existing inequalities across all aspects of life for women and girls.
Now, more than ever, as we fight COVID-19 and protect hard-fought gains made in global health, we need massive and cohesive global investments in health.
The accomplishments of the SDG 3 GAP so far are encouraging, but implementation needs to be expanded further.
Country-level implementation has increased to 37 countries, with many prioritizing primary healthcare reforms.
Our work in Primary Healthcare Accelerator supports government and civil society partners to implement national and subnational work plans. This includes working alongside other partners to provide essential supplies, data, digital health solutions, and other innovations, even in fragile and complex environments.
And in Pakistan, coordinated sustainable financing and efforts to boost the primary healthcare system is paving the way to universal health coverage.
In Côte d'Ivoire, we worked with the Ministry of Health and civil society organizations to support a primary health budget increase of 15% every year.
As part of the ACT Accelerator and with partners, UNITED is leading the work on therapeutics and also access to oxygen in low and middle-income countries. This work is fully complementary to the work of the GAP to increase oxygen supply in countries.
On innovation, WHO and partners help to scale solar-powered oxygen in Somalia.
In countries like Malawi and Nepal, we work with partners like the Health Data Collaborative. That is strengthening data sources so that countries can assess how they're performing against the SDG health targets.
UN Women, together with the UN University's Gender and Health Hub and key gender working group members, have jointly developed a guidance note. The guidance provides very practical actions that decision makers can take to promote gender equality and ensure an equitable uptake of COVID-19 vaccines by leaving no one behind.
It has spurred the development of a new global dashboard for vaccine equity. To give you one example, the dashboard empowers governments, policymakers, and other partners with the very best of data and analytics to accelerate universal access to vaccines.
To align across health partnerships, we're integrating work under the Every Woman, Every Child initiative.
We continue to learn and adapt, to look for opportunities to innovate, and to work smarter in supporting countries to achieve their health-related targets.
With countries in the lead, our collective efforts under the GAP are already helping deliver concrete results across health systems while building more resilient health financing strategies focusing on equity.
When we collaborate, stronger collaboration, that means better health.
Our goals for the next years are to at least double the number of countries in which we're working, to roll out the monitoring framework to optimize our support to and measure our impact in countries, and to continue to jointly support countries to strengthen primary health care.
Together,
Together,
for an equitable and resilient recovery.